Hello. Very good evening to everyone. We are about to start the sessions. Would request everyone to please come in the hall and take your seats. Dipesh bhai, please tell everyone to come inside. Yeah, we'll be starting very soon. Backstage team, please keep on playing the videos. Dr. Anand Shukla, please come inside the hall. Dr. Anand bhai. Bharti. Good afternoon. Would request Dr. Bhavesh bhai to come on the front side and have a seat. Dr. Dhruv Jadeja, please come on the front row. Would request all the delegates to please come inside the hall. We are just about to start. Dr. Anand Bhai, need your okay. So we all have gathered here to learn something. Education is not just limited to classroom, it's a lifelong journey. So to start this journey, we pray to the Almighty, and I would request everyone to stand for a while so that we can conclude with the prayer. Team, please start the prayer.
निर्विघ्नं कुरु मे देव वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you, everyone. I would request our organizing chairman, Dr. Bhupesh Bhai, to come on the stage and address everyone.
Thank you, Dr. Tarun, and Happy New Year and good afternoon, everyone. All our teachers, all our seniors, I'm happy to welcome all chairperson, moderators, and the delegates, and those who are watching on the line our session. It's going to be a little bit intense afternoon to evening, and I'm sure that we are going to have magnificent discussion and a comprehensive interaction amongst ourselves. So I think I wish this conference a great success, and I would like to thank Dr. Jay for putting his best efforts, because he's the important link between us. Thank you very much, and all the very best.
Thank you, sir. And for the first session, I would request to chair the session, Dr. Deepak Dantara. Please come on the stage and have a seat on the right side. Dr. V.K. Abhichandani, sir. Dr. R.C. Damani, sir, to chair the session, and Dr. Nimesh Patel to chair the session. For experts of this session, Dr. Shabbir Gadi, Dr. Rakshit Brahmbhatt, Dr. Binit Javeri, please come on the stage. Dr. Paras Patel. जय ने इनवाइट करो.
Good afternoon, everyone. A warm welcome to all. So let's begin this academic feast, and with pleasure, I invite Dr. Jay for the first talk of today. Ladies and gentlemen, please put your hands together for Dr. Jay Shah.
Good afternoon, everyone. Thank you so much, Dr. Damani sir, all chairperson, faculties, all dear friends. So my talk is basically related to the worsening heart failure. We know that in last 1 decade, the decade itself is going towards heart failure, be it reduced ejection fraction, mid-range, preserved ejection fraction. There are new terminologies like de novo heart failure, remission in heart failure with improved ejection fraction. But amongst all, what we wanted to prevent is that how can we prevent the development of worsening of heart failure. And this heart failure progression is basically nothing but a repetitive worsening heart failure events, which is resulting into reduced cardiac function and ultimately cardiac death. By definition, when we are looking at the overall worsening heart failure events, the development of progressive escalating signs and symptoms of heart failure, which is requiring intensification of the therapy in form of intravenous diuretics, hospitalization for heart failure, or you might require an emergency visit to the hospital to take injectable diuretics. So when is the best time to intervene? Let us see, or let us assume a scenario where the patient is having an acute decompensated heart failure. Patient is being treated nicely in the ICU. Now the patient is being in the step down or in the recovery period, and then patient is getting discharged. Now, after the discharge, if the patient is having first heart failure event, which is known as a worsening of heart failure. So that first event is the starting point of worsening. And if you want to reduce that, that is the event you need to be very you need to be very vigilant about it, and you need to treat that condition vigorously so that you can prevent further course of the adverse outcome. So there are 4 domains of the patient who is experiencing a worsening heart failure event. They are in 4 categories, be it clinical or subclinical, because worsening could be in form of either sign and symptoms, severity of congestion, reduction in the exercise capacity, or in form of subclinical events, either elevated biomarkers in form of NT-proBNP or non-invasive imaging, which is ultimately leading to the development of worsening. Then there are certain emergency department visits, hospitalization. You might require escalation of the oral therapy or injectable therapy. And the most important amongst all is the quality of life, and that is known as the outcome. Because the poor health status and the quality of life, once it is getting deteriorated, it is not only affecting the patient mentally, but financially, and overall emotional health is also going to get hampered. So there are different treatment strategies. We are all aware about foundational 4 therapy. I think Dr. Jai Gopal sir is here. He is a pioneer himself as far as the heart failure therapy is concerned in India. He himself is organizing a very big Heart Failure Association of India conference next month. So he's going to talk about the foundational therapy and the different phenotypes. My role is, whenever there is a worsening heart failure, do we have anything in basket which can curtail that worsening? And that is being done with the help of vericiguat, which is a newer nitric oxide soluble guanylyl cyclic 6-GMP stimulator. By doing release of cyclic GMP, it will help in reducing inflammation, reducing or rather increasing vasodilation in the blood vessels, and increasing renal blood flow in the kidney. So it has got a comprehensive beneficial effects on all the visceras. And on the basis of this, India, or the Indian consensus statement, has been released. The pioneer work was being done by our own, another faculty, Dr. Jagdish Hiremat. He was the pioneer in writing that chapter, which was being published in August 2024 in JAPI, which has stated that how can we subject our patient by initiating the therapy in form of vericiguat to prevent further hospitalization and worsening event. So what the terminology which has been given is early simultaneous rapid sequence initiation of foundational therapy. That means all 4 foundational therapy, that is ARNI, MRA antagonist, beta blocker, and SGLT2 inhibitor, they should be started simultaneously, even though in a lesser dose, but simultaneously. And then you need to keep a close watch or vigilant monitoring for the next couple of weeks as a strong follow-up. And this is the AIIMS hospital discharge checklist, which is showing the importance of each medication and whether the patient is receiving that medication in proper dose or not, and how the patient is going to subject, provided the etiology of the heart failure, be it coronary artery heart disease, heart failure, valvular heart disease, or any arrhythmias. So on the basis of that, Indian consensus on heart failure in 2023, they have given one statement that vericiguat could be considered in 4 different category of patient. One, for the patient who is experiencing an event despite of receiving an optimal background therapy. The most important thing is that there are patients, they are not able to tolerate those therapy. then what should be done? Then there is no need to wait for this therapy to be, rather to not start this therapy, but to start it early. So this is the period where the patient is not able to tolerate the therapy, either because of low blood pressure, hyperkalemia, or because of low EGFR. In that case, you are being restricted by giving ARNI or some like MRA antagonist, or for that matter even a beta blocker because of the hypotension. So let us start with vericiguat, give that therapy, keep the patient on a strong follow-up. Next 1 week, you can escalate the dose from 2.5 milligram to 5 milligram at every 2 weeks interval, and then see whether the patient is tolerating it well or not, patient is able to manage or rather maintain hemodynamic status or not, provided the eGFR is remaining more than 15. Another category is that after an acute decompensated episode, once the patient is getting stabilized, soon after the stabilization, before discharge, let us start the therapy. Same way we are starting with ARNI, same way we are starting with SGLT2 inhibitor. Vericiguat should be started early or soon after the discharge in first 1 week. And that exactly is being given in this particular chart. This chart gives you an idea about the uses of this drug, but what is important to remember is that only one sentence, the first one. Patients stabilize after heart failure decompensation event in a chronic heart failure reduced ejection fraction patient where eGFR is more than 15, systolic blood pressure is more than 100, injectable diuretic is not being received in last 24 hours, and NT-proBNP is less than 5,000. If this 5 category of patients, or rather these 5 parameters are being managed, then you are definitely going to give a background therapy of foundational therapy, and then you can add on with vericiguat for this patient to develop or rather to prevent them for worsening heart failure. Then of course there are the add-on therapy in form of ferric carboxymaltose for iron deficiency anemia, ivabradine for high heart rate, even after a maximum tolerable dose of beta blocker, hydrolyzine isosorbate dinitrile for hypertensive heart failure patient, especially black, and in some of the cases you might require to give digoxin in reduced ejection fraction. So these are the 4 categories which was being given as a cases which was being published in JAPI. That case number 1 is patient on all 4 drugs, that is ARNI, MRA, beta blocker and SGLT2 inhibitor in a maximum tolerable dose, but still symptomatic or NT-proBNP is still very high, you can start vericiguat. Patient on all 4 drugs on a maximum tolerable dose but still develop worsening heart failure, either because of some other metabolic disorder or some other triggering factor which can lead to heart failure. Third thing is the most important thing, where you require a escalation of oral therapy. Outpatient department, you do not require to admit the patient, but on an OPD basis, if you can escalate the dose of diuretic from 1 BD, if you make it twice daily, 2 BD or 5 milligram becomes 10 milligram, that is the way the escalation of oral diuretic therapy is concerned. That also requires an indication of vericiguat. And the fourth one, which is the most common indication where we are using vericiguat, is those patients who are not able to tolerate these 4 drugs due to issues like hypertension, high creatinine, low eGFR and hyperkalemia. So these are the 4 categories. The supportive evidence which is being given is by strong HF trial, which has given a high intensity rapid sequence simultaneous GDMT in more than 1000 patients as compared to the usual care, which has shown a significant reduction of 34% relative risk reduction in strong HF, with absolute risk reduction is in 8% and number needed to treat there were only 12. And what you gain out of it? Significant low risk of death, HHF, reduction in NT-proBNP, reduction in NYHA class, and there is no major side effects. So there are 2 steps. Step 1, quadruple therapy, quintuple therapy on the basis of strong HF, in which you might start with initiation of medium dose and then prioritizing the initial multiple all medication before going for the dose escalation, but starting us simultaneously. And step 2 is quintuple therapy with vericiguat, where you escalate the dose of foundational 4. Along with that, you give vericiguat and then try to maintain the patient on a proper anti-failure therapy. Many a times in our practice, when we have seen that those patients who have achieved 10 milligram of vericiguat, now they are giving better hemodynamic control. Not only that, they are also giving a good control of all the therapies which was not being, tolerated previously. Now they are able to tolerate it because now they are having a better hemodynamics. So these are the 5 categories where heart rate is less than 60, hyperkalemia, less eGFR. These are the categories where you can definitely start vericiguat in this special clinical characteristics. Thank you very much for the quiet listening.
Thank you. I think we'll take the question answers after the 3 talks. Would request sir to invite the next speaker, sir.
Yeah. Okay. Yeah, it gives me and all 7 of us here great pleasure in inviting Dr. Utsav Unadkat for his brilliant talk. We look forward to learning from you. Jay, I have a query that I'll take up last.
Good afternoon, everyone. Thank you for giving me this opportunity, and thank you for everyone being here to have this academic feast. So today's topic is my renal dysfunction in case of heart failure. We all know that heart failure patients are very frail patients, and they are at risk of developing renal dysfunction. And these patients, require utmost care. On top of that, there are, a lot of kidney patients, renal patients who have, who develop heart failure as their disease progresses. So I'll be shedding some light on that. So when we talk about both heart failure and kidney disease, if they both are there together in a patient, there is more risk of hospitalization. There are more rehospitalization in these cases. There is more need of intensive care. There is more need of kidney replacement therapy, and their death, that is the mortality rate, is also very high. So worsening heart failure has direct and independent consequences on heart failure symptoms and adverse clinical outcomes. Nearly half of all patients with heart failure experience CKD with higher prevalence. In acute heart failure, that is to the tune of 53% versus chronic heart failure, that is to the tune of 42%. In Swedish heart failure registry, we have a very high prevalence of nearly 57% who had heart failure with reduced ejection fraction and CKD to the tune of 45%. And 21% had heart failure with mid-range ejection fraction and CKD. 22% had heart failure with preserved ejection fraction and CKD. So when it comes to both these diseases, they both are interrelated. When it comes to the kidney problems, there are 3 phenotypes that we have. First is there is some kind of intrinsic kidney disease that gets precipitated. Second is these patients are generally diabetic, and there is diabetic nephropathy, or they are hypertensive, leading to hypertensive retinopathy. So these are the 3 phenotypes that are generally there for kidney disease patients. At the same time, when you talk about heart failure, they are either heart failure with reduced ejection fraction, that is DCMP, or mid-range or preserved ejection fraction. It can be heart failure with reduced ejection fraction, can be due to ischemia or other causes also. Common risk factors are age on the higher side, race, gender, hypertension, diabetes, and other risk factors. We have lots of modulating factors. That is a lot of systems that get activated in case of heart failure, like the sympathetic nervous system. We have the RAS system. We have the endothelial dysfunction and inflammation that goes on in heart failure cases. So all these things precipitate heart failure and at the same time impact the kidney function. The important pathophysiologic changes that happen over a period of time is there is gradual nephron loss in these cases, reduced gradually worsening GFR levels, so that some medicines that we could have given earlier couldn't be given over a period of time. Then we have progressive renal fibrosis and albuminuria. When we talk about the heart, gradual reduced cardiac output, increased wall stress, and increased venous congestion again impact the kidney blood supply, and this again gets worsened over a period of time. So it is a vicious cycle that the patient goes into, and these patients have readmissions for recurrent heart failure, and their prognosis gets worsened for each admission. So when the worsening renal function occurs commonly in acute heart failure, that is to the tune of 30 to 50% in these cases, when they are hospitalized, they generally have either a decreased cardiac output state or a venous congestion phase. The reduced cardiac output reduces the blood supply to the kidneys. The worsening congestion leads to the venous congestion of the kidneys. So the GFR gradually goes down over a period of time. When there is late phase of the hospitalization, the RAS inhibition can help these patients, and we can control this renal dysfunction to a certain extent. So challenges in management of these patients will be, while treating volume overload, we tend to over-diurese these patients. This again leads to acute kidney injury and worsening renal function. And at the same time, when we start AC inhibitors or ARBs or ARNI in these cases, there might be some renal dysfunction that might be precipitated due to these drugs. So we have to walk a thin line between these two cases, these two aspects, and treat the patient well. RAS initiation is life-saving in these patients despite the renal dysfunction, and whatever the stage of therapy or whatever the stage of presentation, we have to try to start these patients on RAS inhibition, because if we have started these patients, whether early or late, their long-term prognosis gets impacted. So conventional heart failure therapy, when we give MR antagonist or RAS inhibition in the form of ACE inhibitors or ARB, the potassium levels is what we need to monitor very frequently, because it is in the RALS trial, it is observed that hyperkalemia was there to the tune of 13%, for FSS trial 16%, and FSS-HF to the tune of 12%. So as the potassium levels go on the higher side, the prognosis becomes that much poor. So we have to be very careful when initiating RAS inhibition as well as MR antagonism at the same time. And this hyperkalemia increases with decline in renal function. So when we talk about GFR levels, if the eGFR is more than 60, the prevalence is lesser. Less than 60, the prevalence increases. And impact of this hyperkalemia is to the tune of 9%. These patients will have hyperkalemia. 10 to 38% of hospitalized patients who received an ACE inhibitor develop hyperkalemia. So MR antagonism with ACE inhibition, nearly 40% will have hyperkalemia. And 10% of patients prescribed an ACE inhibitor developed severe hyperkalemia within 1 year of follow-up. So we have to keep a regular check on the potassium levels, not only during the admission, but during follow-up also. Therefore, there is a need for a therapy that reduces hyperkalemia incidence in these heart failure and CKD patients. So ARNI is the one medicine that is preferred, even if we can give ACE inhibitor or ARB. Now it is a class 1 indication, and the incidence of hyperkalemia is less in these cases. So it is less likely to cause hyperkalemia and worsening of renal function. In fact, it preserves renal function. So when we start ARNI or any heart failure therapy in the initial phase, we tend to preserve the kidney function over a longer period of time. Even if you are not able to start it in the early phase, try to get it on board as soon as possible, so that you can reduce the rate of decline of the kidney function. SGLT2 inhibitor also same, it helps the kidney to survive longer. What do the guidelines recommend? Initiate RAS inhibition in the form of Valsac as first line therapy in all cases, whether it be SEC 2024 guidelines, ESC guidelines, or Indian consensus. They all recommend ARNI as the first line of therapy in case of heart failure. Then when it comes to dosing adjustment, generally we don't need dose adjustment till the GFR levels are less than 30. So you can give it as a regular dose therapy. So it improves the LV function to the tune of 5.1%, 27.5% increase in quality of life in these patients, and there is lower incidence of elevated serum creatinine levels over a period of time. So this therapy preserves kidney function over a period of time. And RNA delayed the progression of GFR, decline of GFR as seen in this meta-analysis. There is also 11% reduction in risk of worsening heart failure with ARNI. So lesser number of re-hospitalizations and lesser number of prognosis is that much better. So to summarize, the renal dysfunction and heart failure are a real thing. They are there together very frequently. So we need to challenge both these aspects very well. And ARNI is the first line of therapy in case of heart failure with kidney dysfunction, as it helps in preserving the kidneys and the heart at the same time. Thank you.
So we are going to have third talk in this session, and I invite Dr. Jay Gopal, who is a senior interventional cardiologist, director head of the cardiology department, Lakshmi Hospital, Palakkad, Kerala. So over to Dr. Jay Gopal.
Respected chairpersons and dear friends, at the outset, let me thank Dr. Jay Shah and the team ACS 2025 for having invited me to deliver this lecture here. Well, this is an area which is very close to my heart, and I'm very passionate about this. So I think the topic that has been given to me is basically look at how newer strategies, all of us have been hearing this. Now, heart failure, the moment you diagnose this, it's important to understand that this is worse than acute coronary syndrome. Look at the bar on the left-hand side. Acute coronary syndrome, we categorize as many stages. For example, you have the lowest risk, where you try to do some primary prevention. But as you go higher up, based on the risk factors and whether you had an event or so, you have various kinds of risk stratification for acute coronary syndrome. But when you talk about heart failure, and that's what the problem that we really face in the country these days, once they have a heart failure itself, the stable so-called people, once you have somebody with an LV dysfunction and you diagnose them having a stable heart failure, that is no longer in the lower risk. It's actually, they fall into the higher risk category. And the kind of patients which Dr. Jaisha was alluding to, the worsening group, and they are the very extreme high risk patients. So there is nothing like a stable heart failure is what you need to understand. And when we look at our own data, this is what I'm not really going to scare you, but then these are all the facts that has evolved over the country in the last few years. We have had three major registries. Well, I've been fortunate enough to conduct a large registry in this country in the last 5 years. We did more than 10,000 patients in the Indian College of Cardiology registry. What you see on the right-hand side is the ICMR promoted the National Heart Failure Registry, and this is the Kerala component of it, which came back. All these things. Now, if you look at it, the major problem today is ischemic heart disease. And then we also need to understand here that why are we talking about this as a physician? Because these are patients with a lot of comorbidities like hypertension and diabetes in at least about one half of these patients. So it's important to understand this. And what is even more important, we have relatively younger patients and we have more of reduced ejection fraction, unlike what you see in the Western country. And more importantly, why I'm really trying to drive home this point of innovative strategies, because the in-hospital mortality, what we have seen, has been consistent around 7%. If you take it in the perspective of an acute coronary syndrome, like let's say the STEMI, world over, we would say 2 to 4% is an accepted mortality. And in fact, I've been part of the Global Heart Attack Treatment Initiative, the ACC. Our last 3 years has been 2.99%. So what I'm trying to drive home the point is these are extremely high-risk patients and they behave worse than cancer. Because when we did a review, in fact, this article we have actually published recently, when we looked at in Asia, you find the diagrams on the left-hand side. China has a much lower rate, but then people could argue that there are a variety of reasons why, because they're underreporting in many things. But then in India, this is a Trivandrum Heart Failure Registry way back to what we currently seen. This is what it is, even worse than some other Asian countries, what we have nearby. And not only that, you follow them over a period of 1 year. And what we see today is about what is 30% mortality at 1 year has just come down to 20%. But then this again is worse than some forms of cancer. So I think it's time that we really rise up to the occasion and do something about it. And if you compare with the global statistics, look at China, India, US, we are phenomenally doing, badly here. And then, well, at the end of 1 year, again, the mortality remains the same, but again, very high, which warrants some kind of an intervention. And when we actually did this study, we found that, we were talking about what things you could do to prevent this mortality, and that is typically the guideline-directed medical therapy. I would always tell my fellows there are 4, A, B, C, and D. A is the angiotensin receptor inhibitor, or the ACE inhibitor, or ARBs, or the modern one, the ARNI. B is the beta blocker. C is the short form for the mineralocortical, cortical receptor antagonist. And D, for easy to remember, is a DAPA. mean, the EMPA is also part of it. But then what I'm trying to say is when you look at all these therapies, we find that beta blockers perhaps important over a period of time. Even the last few years, we still really lag behind the Western statistics. And the wonder drug, which really brings down mortality, what is ARNI? From it's a dismal 2.6% initially, now it's just come up to 6.69%. So I think we really need to understand that there is a lot of problems in our country, diabetes, a lot of comorbid conditions, chronic kidney disease, AF, very high mortality. Unfortunately, we do not have a data on SGLT2 inhibitors, and it's time that we really do something about it. So that's what actually people all over the world, they also looked at the evolution heart failure trial. They also found that it's extremely difficult for patients to be on the DAPA and the newer molecules, and the discontinuation rates are very, very high. We were talking about the fundamental 4 pillars of therapy, the ARNI, the beta blockers, MR and SGLT2, ABCD, which I just mentioned about. Of course, not to mention, forget about the diuretics, because decongestive therapy is also very important. And what's important for physicians to understand is, if you look at this graph, what you see on the left-hand side, in fact, this is the mortality benefit. If your patient is on all 4 drugs like the ARNI, the beta blockers, MR and SGL2, their mortality is probably the least. And that is irrespective of the age, whether you are 60 years, 70, 80 or 90. In fact, if you add all these 4 drugs, you get an extra 8 years of life in a 55-year-old individual, extra 33 years in an 80-year-old individual. That's the kind of effect this guideline-directed medical therapy has. And the question remains, what do you do? Why should we be starting this immediately? Why the rush? Why are we talking about it? Because, and that's where the hospitalization becomes very important. We today know that when you start these drugs, they are pretty safe even early. What was thought to be a contraindication beta blocker during our medical school days, today is one of the indicated drugs. So I think it's important that we start it early because the safety has been proven, significant benefit regardless of the background therapy, and opportunity also for close monitoring in the hospital. So that's why we need to really push it. And also, you just heard about Dr. Jay Shah talking about a strong HF, which I'll come to. And this, in fact, I keep quoting this article by Fauner way back in 2007. This came in. If you are able to start and initiate a therapy like a beta blocker, or let's say even an ACE inhibitor while in the hospital, the chance that these patients would continue would be very high, 93%, compared to if you are starting this as an outpatient. People do not adhere to a therapy which you start in the outpatient. Whereas if you start it as an inpatient, they know it's an important drug and they keep moving, following that. And that's also the one important thing. And then more importantly, today we have the strong HF trial. In fact, this is a cardiac anesthetist. Mebasa is a cardiac anesthetist, had an opportunity to interact with this guy. In fact, this is one of the studies where they actually randomized in starting with this conventional therapy, slowed initiation, all the serial escalation of drugs, whereas the optimization initially itself start with half optimal dose, keep on increasing it in 2 weeks, and then what happens? And when they used this, they found that majority of the patients were able to attain the full dose or optimal dose of the target therapy at a much earlier stage. And not only that, they found that when they followed up these patients at 180 days, they had improvement in everything. For example, the respiratory rate, the peripheral edema, jugular venous pressure, and not only that, they also found that the events came down considerably. The high intensity care, they did extremely well. And that's perhaps one of the important reasons why you should initiate this while they are in the hospital. So that's why the acute hospitalization becomes an important point. And not only that, when this is one of the recent data from the Get Well registry, to the target dosage registry from 2016-2023, they found that they actually, out of the group, 82.2% were eligible for the cardiovascular therapy, but in reality, only about 15.3% really get it. So I think there is a lot to be done. And when you start analyzing why this does not happen, today we all know for sure, if you start your patients on guideline-directed therapy, the outcome is really better. But then it really does not happen because even in the Western countries, if you look at the target dosage of all the 4 drugs, it's just 1% in all the registries. Whether it's a CHAMP registry or the newer registries, it's just 1%. So in a country like India, you can understand how dismal it would be. There is a suboptimal discharge planning, there is a non-adherence, in fact, a lot of inertia and delays in seeking medical attention, many things, thus creating a need for a heart failure program. And also, today we know that there are ways to look at it. If you have a checklist while they're in the hospital, have a scoring just like what has been mentioned, somebody is interested, they can go to this, and what the scoring would be acceptable would be more than 3 to 4 or more than 5. And this is one way of looking at it. And we also have seen that if you have a team which takes care of your patients, for example, a heart failure specialist, a physician, a pharmacist, dietitian, nurses, this really works wonders. And in fact, in the Western countries, they have found that the mortality comes down by about 10% just by using a team. And in a smaller context in Kerala, in 1,400 patients, we did this study for a few weeks actually. What we did was we used again the same model, used a heart failure nurse, and then we just followed up this patient. And when they tried looking at the weight gain and whether the questionnaire, whether they're taking these medicines, the prescription of guideline-directed medical therapy just at the end of 1 month started rising up. So there's a lot of things that you could do by having your team, and the outpatient following schedule when the follow-up also increased considerably. So this is some simple measure that you could do. Well, the same thing was seen in the titrate HF registry, 4,288 patients, 45% were on quadruple therapy, and when these were actually, there was a dedicated heart failure clinic to follow up these patients. So that is one of the innovative strategies that you could start in your clinic. Secondly, we also know that the team HF, which again, they also used similar clinic, and they found that this guideline-directed therapy jumped from 21 to 88%. And again, significant improvement in the NYHA class, improvement in the ejection fraction, reduction of the NT-proBNP, and also less of mitral regurgitation and better outcomes over a period of time. Well, there have been a lot of newer innovative strategies. For example, the Western world, they have enough finance to do all this. Digital technology, we still have a lot in our control. When you use a digital technology to follow patients again with the usual care, this has been found to really work wonders. I mean, these are things which have been proven, but again, on a larger scale, to implement this in a country, it is extremely difficult. And we also went one step. We thought another initiative was probably the use of too many pills. So one pill, if you could combine everything, the A, B, C, D, together and put in a poly pill. In fact, we wanted the first pilot program to be done in our hospital in the world. In fact, this was funded by the Northeastern University of Chicago. Unfortunately, DCGI did not give us clearance. It's gone to Sri Lanka now. And the first paper is actually ready for publication. So there are a lot of new things which I'm not really going to dwell on. You decongest them better, start them on early drugs and follow them up better. And when we looked at what is happening in the Asia Pacific region, I was fortunate enough to be part of this group. We did a survey out of which the majority came from India. In fact, you see that the majority of these surveys, and that too from tertiary hospitals in the cardiologists took part. And what we saw, the key aspects of the survey was lack of patient awareness, which was about 80%, which is no wonder at all. But more importantly, what is shocking for us is a poor physician awareness of the diagnosis and treatment, which was 72%. And that's why we are really talking about this. And echocardiography, people today rely on echocardiography as to key thing for a diagnosis. So we have a lot of innovative strategies where, we like the STEMI care. We would like the patient from the center to go to the periphery and interact with the physicians, GPs, the pharmacist again directly with the patient, the nurse with the patient and the healthcare workers and the primary health center and so on. And we all know that there are many things, there are many reasons why this does not happen. So we really have to look at the change in systems, because patient. But what we would like to focus today, and more importantly, about something which we really wanted to, Dr. Jaisha was part of this program, is basically to improve the physician awareness. And that's because if you can start this at an early stage, you really prevent mortality. Well, when we looked into why this is not happening, maybe as I mentioned, the awareness amongst the physicians is less, but more importantly, there are a lot of challenges with the physician faces in his practice. Low blood pressure, you can't start them on any medicine. For example, worsening renal function, you used to scare an MRA or an ACE inhibitor. Concern for low blood pressure. So there are many low cardiac output states. So there are many things, and there are a lot of comorbid conditions which along come with this. For example, atrial fibrillation and chronic kidney disease, which again actually creates fear in the minds of the physicians. So I think there is a lot to be addressed. And when we look at let us say, there are a lot of guidelines coming out. In fact, the recent heart failure guidelines, if you look into it, that comes as a big document. Who has the time to really go through it? And every practicing physician who's busy in his outpatient, can he have a complicated algorithm to just refer to this? We find this to be really a futile attempt. And that's why we thought we should go one step further. This was a consensus which we took from about 40 top cardiologists in the country. And that's what our essence of this talk is about, simplifying communication for the physicians. What we call it is the Indian heart failure profiling wheel. And this is a very simple thing which will be delivered to every physician. Our hope is that this will reach the desk of every physician in the country. We have the heart failure reduced ejection fraction there. The primary thing is to relieve congestion, use a diuretic, and then you have the 4 pillars, A, B, C, D, which I had mentioned earlier. And then every condition that a physician sees is started out. What is seen in green is indicated what is yellow should not be used. So whereas what is in red is a contraindication. So I think you have a patient, you have the various problems like the normal blood pressure, all four are indicated, hypertension, all four. So it's sort of a checklist for the physician to see what would be appropriate for your given patient. Normal heart rate, you will have all that, whereas a low heart rate, you will not have a beta blocker, which is in red there. Again, more than everything, if the heart rate is more than 70, then you probably, despite these drugs, you will add an ibuprofen. So every comorbid condition which the physician would see and manage would be really be addressed by this heart failure profiling wheel. And this is what we thought about hyperkalemia. See, what you see in red, you cannot use an MRI. Whereas what is in green should really be prescribed. Coronary artery disease, all four would be there. So this is a very simple thing which will be available on the physician desk for you to understand the patient better. Today we know that the heart failure 1% prevalence, it's such a significant number of patients. Only about 10,000 qualified cardiologists the country cannot really manage this heart failure problem. So until and unless it comes to the physician level, this cannot be tackled, and that is what we need to really want to project and spread. So we also went one step further. The physicians, it's not only the physicians, cardiology, when we looked at it, in fact, some of our patients, the guideline directed medical therapy, you talk about ARB, we still see a lot of telmisartan prescription, which is very sad. The only ones are either losartan, valsartan, or candesartan. So we know that there is still a gap amongst the cardiologists. The same thing holds good there, but we have gone one step further, because for the cardiologists, they may have to really look at patients. It's not just a heart rate. Sometimes you have to go into depths, find whether they have a left bundle branch block. The CRT is a new therapy which will really reverse this problem, and sometimes some of these patients do well. So this is actually meant for the cardiologists, and this again is going to be circulated for all the cardiologists in the country. So again, we have something in store for the heart failure for the preserved ejection fraction. Today, we know there is the only guideline directed approved drug is an SGLT2, but there are a lot of newer drugs coming up. For example, you have the GLP agonist, the Finrenon. You must have heard about it. It's just got the initial trials cleared. So I think there is something really interesting and something really encouraging that we see in this context of heart failure preserved ejection fraction. But then again, these are the group of patients which should really go to the physicians, because this is a disease of comorbidity. And you probably at this stage of time, point of time, you can only improve the quality of time for these physicians. So I think this is a new thing, which is a new innovative approach. In fact, I'm really thankful for all the 40 people who really took part in this deliberation over a few days to really put this into the right perspective. And this we hopefully think will take the physicians to a better understanding of our heart failure program, and also take them one step further in the management of heart failure. So this is what it would really look like. You will have this distributed in your, and it's also fortunate that one of the major industrial partners, Sun Pharma, have really helped us in pushing this further, this cause further. So I think the final thoughts before I end is that I need to emphasize again that heart failure, we are going through an epidemic, and this is a very dangerous thing for the country. The outcome is worse than some forms of cancer. But then what was really a disease which could not be treated 3 decades ago, today at least has really 4 classes of drugs which could be employed and millions of lives saved. So I think it's important that we need to create awareness about GDMT, and that's the first task by using this model. And second, importantly, for the physicians, I think it's also a disease of comorbidities. A lot of people should be involved. It's always a team effort. And this again, whatever has been mentioned here, it would be a really useful checklist for the physicians. And thirdly, this is an easy available reference. I think you can, it's on your desktop. Any problem, for example, you have an atrial fibrillation, you have a chronic kidney disease, this is on your desktop. This is an easy reference card for you to really simplify the treatment algorithm. And this finally would turn out to be a simple algorithm for the practicing physicians, in the hope that you have better hope for heart failure patients in the future. Thank you all for the kind attention.
Thank you, sir. The house is open for question and answers.
Yeah, sir. Thank you very much for that very elegant talk, and it made us all aware of several lacunae that we face in our day-to-day practice. Now, I have a few queries I want to learn the answers from you. What is the role of remote pulmonary artery pressure monitoring as an innovative approach for managing heart failure patients, reducing the rehospitalization rate?
Yeah, that's an excellent question. In fact, if you look at any of the major, let's say the top hospitals in the western part of the world, it is always it has become a very important tool to assess the pulmonary artery pressure. As you all know, one of the major problems that you have in a worsening left-sided heart failure is increase of the right heart pressures. So if you can, in fact, this is what we really do in our clinical practice also. Though in a country like India, we don't look at the PA monitoring. At the bedside, what we are looking at is the right heart pressures by looking at the IVC side, and sometimes the PA pressure, which indirectly comes from a TR jet. And the usage of diuretics based on this would be an appropriate step to decongest this patient. So there have been a lot of data to suggest that if you are able to do a PA monitoring, and today the stickers are available, there is actually a device which can be applied, and this actually keeps on recording, just like your Apple Watch, the smartwatch keeps track of your heart rate. Today they have this system we can tell you about, and then can even give you a red flag, sometimes give an alarm. And if the PA pressure keeps rising up, that's a bad sign. So your medications could be titrated. And for example, sometimes some arrhythmias are well known to produce these problems. So I think it's mostly used as a research tool, and also in some of the advanced, but on a daily practice, it's not feasible because of the exorbitant cost at this point of time. But it's an innovative thing. I think we'll probably have some sensors or things like that in the future, which will probably give us more information.
One more question, if you permit me. Do you reserve any comment on hospital at home concept for managing heart failure patients?
Well, there was a beautiful article just a couple of weeks ago. I don't know how many of you got to see this. In fact, the statistics says that the per expenditure for the given patient for his terminal problems in India is much more than what you see in the Western world. In fact, at least in Kerala, for sure. People towards the end of their life, they bring them to hospital, they want ICU care, 80-year-old man, and for whatever reason. Unfortunately, there are few things that you can really do for them at that point of time. So I think this is important when you understand whether the patient has a stage 4 heart failure beyond salvage. I think many things it's probably better treated at home. I think that concept. And today, the nurses probably encourage you to take more interest in this. And we have to, if you have to think about this in a much larger way, I think it is important that we do a lot of educative programs for people in the.
I think in the West, they already have a well-defined protocol for
Yes, they have the palliative. Yes, it's actually sort of a palliative care. In fact, that I just show. I don't know whether I showed you that slide. So this is actually becoming a more fashionable and more, more appropriate. For example, people in the nursing homes could be. In fact, it would prevent a lot of hospitalization and expenditure for the exchequer as well.
Because all the 4 pillars have different pharmacokinetics. How they include those ingredients into it?
Well, we had a lot of thoughts about this. It's a very good question again. In fact, the biggest challenge for us was to use what ACE or ARB. Beta blocker, of course, bisoprolol has a long duration of action. So bisoprolol was the first choice. Eplerenone, because the distressing side, the aldactone was, again, the formulation had a problem. So eplerenone was the second thing which came out of it. But the major problem was what the canticidin was the ideal drug. Unfortunately, it was not available only in it's still only one company markets it. So then this came, question of whether everything would, so that is why we wanted an evidence where the pharmacokinetics and whether it remains the same vis-a-vis the individual formulation. So this was the first part which the DCGI wanted. DAPA obviously again it's a once a day. There has been no major issue in terms of interactions or the food. So it was believed that if you have all the 4 together, then it would probably be there would not be much of a pharmacokinetic interference. But then we were not able to test it. Honestly, unless you test it, you can't really come out with the results. So a company based in Hyderabad was willing to give us the technology to do this, and it was all set. But then DCGA till date has not given approval for this. But this drug is the whole research has started in Sri Lanka because it got approved very fast there. So in another 3 months' time, 4 months' time, you would hear about it. The first paper on the design has actually just gone for publication.
Dr. Jay, there is a question from audience.
Yeah, since we have Dr. Hiremed sir, if you can just share some ideas regarding virtual heart failure clinic.
Yeah, it's easy to understand what it is. Implementation is always a challenge, but somebody has to take it up and work on. like what you have done, beautiful ideas which have been put to practice. Virtual heart failure clinic is possible. Actually, from Corona days, we have started online consultations, and most of the heart failure patients may not need anything else than weight, blood pressure, and maybe an anti-proBNP result out for a follow-up. So this can be followed up by the people, and it can be worked as a virtual heart failure. One more point was about vericiguat. One of the words or phrase that is used for vericiguat is a facilitator drug. That means where the hypotension is there, hemodynamics is not stable. So you start that. At the end of 3-4 weeks, the hemodynamics get stable, and the other drugs can come in. So it is one of the, you mentioned all that except for the terminology. That's why I said I would use that.
Just to add on to that comment, in fact, we have coined a new terminology for this. So there are a group of patients who cannot tolerate any of the GDMTs. For example, the pressure is low, the renal dysfunction and all that. But then it's an ideal opportunity to use vericiguat, and they do well. And once the function improves over a period of time, you are able to put them back on the GDMT. So we have coined a new this thing called bridge to GDMT, like a bridge to transplant. It's a bridge to GDMT. Start on vericiguat, and they do well. Some of them are really doing well, and we are working on this project now.
Category where the patient is not able to tolerate this therapy, and you need to start this therapy as a facilitator, and then you can restart the GDMT.
A significant number, I would say, easily about 30 to 40%.
Yes. It's an add-on therapy.
The other thought was about the polypill was you can combine the three. Those who are once a day medication, beta blocker, MRA, and DAPA. So they are all, one pill will be all once a day medication, and ERNI can be given separately. That also will reduce the pill burden significantly.
Yeah, the only thing is ARNI has to be given twice a day as of now.
That's why keep it outside, and the other three can be put in one pill.
Yeah, so we actually want to test this as an ARB. So
then you are resorting to little inferior treatment.
No. Yeah, we have to agree.
Dr. Jay, I have a query.
It's facilitated and you can introduce the other drugs. Can we withdraw vericiguat after that?
Don't. I think somebody has a refractory error and you put a specs so that he can see now. So we don't remove the specs. So similarly, give the medication so that cost. Yeah, cost.
But I think there is also one more objection. This trial was done only for 10 months. This Victoria trial went on only for about 10 months. So the data, long-term data is not available. In fact, this same question, we had a few patients where we withdrew. In fact, it's recommended not to take it off. But then we withdrew after putting them on guideline-directed medical therapy, nothing happened, and they all remained the same. So this is again something, that's why this new thought process, whether it could be a bridge to CAM, because it's an expensive drug in India. So whether too early, but as per the data, I think we need to continue.
Dr. Jay, can I have a quick question for you? So this is a teaser, and pardon me, it doesn't, I mean no offense to anyone. Last year there was a heated debate, and one of the very learned cardiologists from Bangalore pronounced vericiguat as a glorified digoxin, and there was a literal war in the hall. So you have done your job brilliantly. We are very convinced, but do you have any comment on such an observation? It was an extreme observation.
So that question gives your answer from Sir's slide, where it has shown that when you are using three drugs, MRA, SGLT2, ARNI, beta blocker with vericiguat, the mortality reduction is significant, which is not there with digoxin. Digoxin mortality benefit is seen only when it is being combined with ARB, provided the patient is having normal sinus rhythm, not having any other comorbid, the relative contraindication for digoxin. Otherwise, it's not a glorified, because ultimately digoxin and the mechanism is cyclic GMP stimulator.
Yes.
Vericiguat. The idea of using vericiguat is that provided patient is not on nitrates, because otherwise it will lead to profound hypotension. So nitrate therapy should be curtailed. Excessive diuretic therapy should be curtailed when we are using this. So I don't know if
bridge
Sir has...
therapy, as Sir said. So I meant no offense. Can I have one question for
Yes.
Dr. Unadkat?
Yes.
So, sir, yes, you were obscured. So, I want to learn from you whether cardiac output or cardiac index, does it matter when we consider the prevalence of, worsening renal function in patients of all grades of heart failure? The prevalence has been identical in HFpEF and HFrEF. So, does cardiac output or cardiac index matter?
For that, I'll have two aspects. I'll divide the patient into two stages. Like first is the patient having intrinsic kidney disease or not. So in that case, if the patient is having that, then the cardiac index itself is not going to be the primary contributor. If the patient is having no intrinsic kidney disease and the patient is only a heart failure patient who is having a gradual worsening of kidney function due to low cardiac output or chronic congestion, then the cardiac index matters, and over a period of time, if you are going to improve it with the help of ARNI, and if you are going to improve it with the help of vericiguat, then these patients tend to do better over a period of time. Yes.
Diuretics remain the main culprit of causing acute kidney insults, especially in acute heart failure
That's why
patients.
in all the guidelines, sir, diuretics as and when required. So once you attain normovolemia, you have to tailor down the diuretics as much as possible. Only MR antagonist, you can keep it on over a longer period of time, but loop diuretics, keep it as low as possible or avoid if possible.
Can I have, in connection with this, in most of the Western countries, the heart failure patients are managed by changing doses of diuretics at home with the help of weight, with guideline directed therapy going on. We tried it in around 30 patients or so last year, but it bounced back very badly. So what could be the cause, or how they are successful and we are not, or even if they are not successful?
So there is one aspect of home heart failure therapy in terms of weight. Over a period of 3 days, if the patient is having around 500 gram weight gain, then they are having significant fluid accumulation, and you can maybe give a 1 or 2 dose of torsemide and wait and watch. Second thing is, if you are not maintaining salt restriction again with it, probably there are other aspects that you can look into, salt restriction, or whether the patient is having worsening kidney function, regular check of the renal profile. These all things I think they should be done at the same time. And significant thing that I think is these patients are very old and frail, and compliance also can be an issue in these cases. So I think these all the aspects should be looked into.
My question is to Dr. Jai Gopal, please. Thank you, sir, for an enlightening presentation. Before I ask my question, I like to say something. Some people are like human medicine. You spend some time with them and you learn a lot. हमें यूं ही आदत नहीं है किसी पे फिदा होने की, लेकिन आप में बात ही कुछ और थी कि हम संभाल नहीं पाए अपने आप. Now my question is, sir, you said stable heart failure, that's the high risk group. I would assume multifactorial. You also mentioned about what is the rush. Obviously, the dictum always goes for everything, catch them young. But now my question is, as Dr. Jay mentioned about vericiguat, probably in worsening heart failure. Now my question to you is, would it be advisable to even use in a stable heart failure, or are there any data which suggest that when initiated early, even without a worsening, does it favorably favor the eventual outcome or not?
Yeah, that's a very, very valid question. In fact, if you look at this trial, Victoria trial, the cutoff was 45%. 45% was the EF. And all that they went by is whether they had one episode in the last 6 months and in 9 months of an event. If you look at the rationale and the way the mechanism of action, it's definitely, it's very attractive. I think because it's probably more on the vascular. That's the essential difference between digoxin. So this definitely would stand to reason. I think this drug should be started much earlier. And the corollary to that is that there are actually, when they studied this Victoria trial, they dissected into various quartiles, like the various the severity of heart failure. They found that if you have a burnt out heart failure, where your NT-proBNP is more than 4,800 and something, it doesn't work. So again, there is a cause that this has to be done much before they deteriorate. And it's an add-on drug. But I think, I mean, but the problem in a country like India is that we get to see this prescription without any GDMT in practice. So that's something which really has to be discouraged.
Well, again, if we are comfortable with all 4 drugs and patient is stable and maintaining his lifestyle also, then is it necessary that you should start it earlier, looking at the cost also?
No, I don't think we should start that. If they are stable, if they are doing well. In fact, the one good thing about ARNI, that's the only drug which has shown an improvement in ejection fraction over 1 year. So if you see that kind of a difference, I don't think you need to start them on placebo.
But at the same time, to add to what Dr. Jayagopal has very beautifully clarified, that there are at least, Dr. Hiremat was also saying just now, that at least 20 to 30% of patients in the clinical practice who have either absolute contraindication to one of the components of GDMT or cannot tolerate 1 or 2 components of GDMT because of prohibitive blood pressure, prohibitive hyperkalemia, or prohibitive rise in creatinine or renal dysfunction. In such patients, suppose you are able to give only 2 pillars out of 4. Why not very simple? That is my question.
Yes, I agree. And in fact, there was a brilliant talk recently by Dr. Tiny Nair, where he was suggesting that the burnt out. When if you have a heart failure patient in the almost NOHA class 4, their ARNI does not work the way you expect because of hypertension. They don't tolerate for a variety of reasons. But these are the sort of patients which are there in the consensus trial, which did remarkably well with ACE inhibitor. So I think choosing a patient is very important. What stage? And there probably ACE inhibitor works better than an ARNI. So it's not that for everyone the discontinue. And we also looked into the data where some of these patients discontinued on ARNI, and those were patients who had 10% discontinued ARNI. That is never mentioned in any trial. Those were patients who had significant hypotension. So I think once you have that group who would not tolerate, there probably adding Versigort instead of ARNI would be the choice, would be the way to go about it.
One quick comment is Victor trial is on. End of 2025 will get the result. This is about the chronic heart failure that you are. If we've had Victoria, which is for worsening heart failure, Victor is exactly like the DAPA HF and paradigm and other things. So we'll come to know whether it is used in early in chronic heart failure, OPD type of heart failure or not.
Thank you, Dr. Jayagopal, Dr. Utsav, and Dr. Jayasha for enlightening us. I would request Dr. B.K. Abhichandani, sir, to facilitate our speaker, Dr. Jayagopal, sir. Please come on the dais, sir. Would request Dr. R.C. Damani to facilitate our next speaker, Dr. Jayasha. Would request Dr. Deepak Dantara to facilitate our third speaker, Dr. Utsav Unadkat. I would request Dr. Bhupesh Shah to facilitate our chairpersons, honorable chairpersons. Dr. Bhupesh Shah. Would request Dr. Dhruv Jadeja to come on the dais and felicitate our experts. Dr. Dhruv Jadeja. Thank you all the chairpersons, Dr. Bhupesh Bhai, and thank you, Dr. Dhruv. For the next session, I would request to chair the session Dr. Naim Kadri. Please come on the dais. Dr. Anish Chandrana, to please come on the dais and chair the session. Dr. Devang Shah and Dr. Dhiren Joshi. For the same session as experts, I would request Dr. R.V. Shah to come on the dais, please. Dr. Mayur B. Shah, Dr. M. Syed, and Dr. Mustafa Rangwala. Would request Dr. Anish Chandrana to please invite the speaker. for this talk.
Yeah, good afternoon, everyone. And we have been into a very perfect discussion on heart failure in the previous session. Now, I think moving little further down in terms of prevention is concerned, I invite one and only my dear friend, Dr. Jagdish Hiremat, to please come on the dais to talk on turning the tide against heart disease. We all have known that India is a country where more than 35% of heart attack happens before the age of 50. And out of total death, which happens because of coronary disease, 1/4 are in quite young age. So I think we need really huge, robust and comprehensive efforts. And to enlighten us on this topic, I invite Dr. Jagdish Hiremat. Sir, please.
Thank you. Thanks for the invite. It's always a pleasure to be near Sabarmati. You see, the level of evidence goes by like this. In mathematics, it is 1A, physics, chemistry, biology, the medicine that we practice, social science and philosophy. It goes down to 2D. And anatomy, physiology, biochemistry, medical, and prevention actually has the least evidence related to that. So I have the freedom of divulging into something which I feel is right. Pardon me for that, but I feel the message will be loud and clear that we need to prevent. We all know that, but we'll know some guidelines related to that. Of course, preventive cardiology is a proactive, patient-centered, in which the clinician, team of clinician, non-clinician, assess the cardiovascular risks and implements a comprehensive strategy of risk mitigation to prevent cardiovascular disease and its clinical consequence. That means we have to first assess the risk, which is so difficult in India. There are no scores at all which we monitor really. I feel the Q-RISK-3 score, which is really a British score, it has a lot of Indian patients were involved in managing the score. If at all you want to use, I never use a risk score at all. So it's interesting to see how the transition of cardiovascular mortality takes place with affluence of the countries. For example, in African countries today, there will be famine and pestilence. That means 10% deaths in cardiovascular disease, that too lot of rheumatic hearts. And the remaining are infections and Chagas disease and things like that. This is what kills the patient with cardiac patients. The second step is where maybe some Middle East countries, maybe Pakistan, they are the countries wherein you 10 to 30% deaths due to cardiovascular disease, and they die of increased salt in the food. There is no awareness. The hypertensions are not diagnosed, and they die of intracranial hemorrhages. And of course, the residual infective things continue. Whereas the third one, where India is today, is degenerative and man-made disease. 30 to 60% of the CVD deaths are due to lifestyle diseases like what we know, diabetes, blood pressure, and maybe atherosclerosis. Europe is here, delayed degenerative, below 50% cardiovascular disease. Their community awareness, they did a lot of work towards prevention, and that's why they have moved into reduced smoking, correct diet, regular weight, and that's why their deaths are due to old age disease, Parkinson's and dementia and stuff like that. And fifth is where the USA is today probably. Gone through all this, and now there is social appeal, mass shooting and bombing. This is what takes place there. So we are here, and we should now know that we must attack the lifestyle diseases with a lot of science involved in it, but a lot of thought process involved in it. And look at the achievements in public health in the 20th century. It's only up to 2000. Beyond that, graph will still go down. Total cardiovascular diseases after about 1960 or so started going down. Disease of the heart going down. Coronary artery disease going on. Strokes going down. And this is somewhere where the statins came onto the scene. And of course, social awareness, smoking and all this thing happened in United States. So a new medical graduate today in USA doesn't want to be an angioplasty doctor. He wants to be a CRT express, electrophysiologist, because that is where the market is. So coronary artery disease is going down. I hope this happens to India, because it's such a phenomenal change that it saves a lot of health expenditure, and India can save a lot of money and spend it on ISRO. So where is India today? India, urban is here, and affluence, urbanization, education is on the x-axis, and all these hypertension, lipid, diabetes are on the y-axis. So as affluence, urbanization and education goes on increasing, all these things go on increasing, then the countries form a summit and then start going down, like what has happened to Europe, North America, Australia and New Zealand. India is on the upswing. Maybe in the next 20-25 years, we'll have a lot of cardiovascular disease, and then hopefully we'll start going down. My idea is today, for our own sake, our individual sake, our families, our social group, our WhatsApp group, can we start the downward journey on our own? It's possible. Maybe the entire society may not happen, but every doctor can represent a role model of health, and then start working on this, and it will result into a downward journey from here. Another important factor here, see, Russia was merrily going along with these 4 countries, but in suddenly 1993, Gorbachev happened to Russia, and suddenly you can see that it's gone up. So that means social stability also matters a lot, and that's why it is important to have a very stable government and other things. So chronic stable is a hard atheroma, you all know very well. Suppose this atheroma was not to be formed, is called primary prevention. Second is where it forms a thrombus, where it breaks, forms acute coronary syndrome with lot of platelets and a few red blood cells, and it completely forms a red blood plug, that is a myocardial infarction. So the basic thing is a chronic atheroma which breaks and finally leads to events. So preventive strategies would be a major change in small community versus minor change in major community. For example, you do 300 angioplasties in a year, it is a major change in a small community. But you reduce the incidence of smoking in Ahmedabad by 2%. It will save you 500 angioplasties. So that's why preventive strategies are like that. Introduce a small change in the community and you will find the results, whether it is diet, whether it is exercise, whether it is all the talks that we go on, smoking and other things. So there is primordial prevention, primary prevention and secondary prevention. So I would say that suppose you want to alter the genes and the person is born with a smaller risk, is called primordial prevention. Suppose somebody is born with some genes, prevent formation of atherosclerosis is primary prevention. Suppose somebody has atherosclerosis today, preventing ASCV event is the secondary prevention. And this is my own strategy of preventing recurrent events would be tertiary prevention. So all these 4 types of preventions are possible and we'll just delve into them in the next 20 minutes. So primordial prevention, actually what is to be done is genetic mix. The Indian strategy of marrying in the same gotra and all is not correct. In fact, there are Indian communities where they absolute no for the same gotra. So that's a correct scientific strategy. And that's why we should be avoiding, rather encouraging intercaste marriages and other things, because that will lead into genetic mix. Lifestyle has a little role to play here because a person is not to be born with a disease. So it's only those who have family history should be careful, like in marriage's time, you can ask the history if there is arranged marriage and things like that. My surgeon friend from Pune, his son got married to a Japanese girl, Shoko. So this is really genetic mix, and I'm sure the genetic mix brings down the overall atherosclerotic incidence in this and in their next families, next generation. So this is a 38-year-old man who's undergone a bypass surgery. You can see the oxygen line here, and see the dense arcus juvenalis in it. This is arcus juvenalis, which means his LDL levels were 260, and this kind of a patient were in a rapid, progressive, aggressive atherosclerosis, premature atherosclerosis. And one Yemenis girl was sent to us for aortic stenosis, but actually her problem was a autosomal type of a hyperlipidemia. All these xanthelasmas over there, tuberous xanthomas and xanthomas here. And actually her aortic stenosis was also related to this deposition of cholesterol in her aortic valve. So a lot of controversy related. She was 9 years old. I sent her back to Yemen. I didn't treat her aortic stenosis also. I'm controversial, but okay. So the metabolic and diabetic related risks that we have, I call this central obesity as a metabolic sin, not as metabolic syndrome. See here, it is a metabolic sin because you can prevent it from the beginning, and if at all you have it, probably you can control it as time goes by. So these waist circumferences, and you know them very well, but metabolic syndrome not only increases the atherosclerotic risk, but can also lead to multi-organ system dysfunction. It's not the bad looking paunch, but it is a fat which gets deposited on the pancreas, leads to a less powerful or less quality insulin and triglycerides and other things that follow with it. There is a concept of thrifty gene. This is by Dr. Yajnik from Pune. What he says is, or Barter's hypothesis maybe, a child is born underweight because of various reasons, and the grandma thinks that this should be fed well and let him be normal boy at the time when he goes to school. So an underweight boy is fed so well that at the end of age of 5, when he goes to school, he's probably a little obese. And the thrifty gene that has inside cannot handle this overfeeding in the early ages. And that finally leads to metabolic syndrome, early diabetes and other things. So that can also be prevented. It's a very simple thing to remember. So let's come to now, from primordial prevention, come to preventing atherosclerosis, that in formation of atheroma plug. This is by maintaining targets of risk factor like diabetes, weight, blood pressure, high LDL cholesterol. It's also related to lifestyle change, because lifestyle change will make a difference here. Generally, a 75-year-old comes who's triple vessel calcific disease, and the family asks me, what is the dietary control that we should offer? I said, you in the 40s, you go for dietary control. Let him eat very merrily, or at least don't be so strict about his diet. Statin and aspirin only in special cases. Aspirin is not to be used for primary prevention in ladies, and statin, aspirin in primary prevention in men also in very select high-risk patients, not otherwise. So aspirin, which was a bane of everything initially, now is slowly waned off, and now it is to be used. The statin becomes even a drug for primary prevention. So whether it is diabetes, tobacco, all these other factors you know very well, but I want to bring to you some other risk factors like vitamin B12 or homocysteine deficiency, vitamin D, LP little a, pollution, type D personality, sitting in one place for more than 2 hours. Sitting is akin to smoking. So if you want to do that, I think we should do work on the sitting part also. Periodontitis, hypercoagulable state, frailty, CKD and high heart rate. All these are risk factors, and one can work on them to achieve primary prevention. Non-compliance of medication. Somebody is a diabetic, doesn't take medicines well. Hypertensive, doesn't take medicine. He's non-compliant to it. Then his risk is very high actually. And this is pigmented knuckles, giving high B12 level. He's a rich man, golden rings in his fingers, but obviously he's purely vegetarian and B12 deficient. Vitamin D is there between 11 a.m. and 3 p.m. gives you the vitamin D dose, not the early morning. So we should all be aware, and maybe how many of us can go 20 minutes of sunbathing 11 a.m. to 3 p.m.? I don't know. So it's not practical in India. So despite being in a sunny country, we have such vitamin D deficiency. How it contributes, it doesn't matter. My thinking is it's a simple thing to correct. Why is it called vital amine? It has some vascular implication. Correct it. It's easy to correct that way. Pollution is now clearly recognized as one of the factors. In Pune, there is an area called Nulstop, a very busy area. There, all sparrows have disappeared from there. Because I say that the sparrows know that pollution is a problem, but human beings don't know that pollution is a problem. And there have been, this slide is just to show you that there is a lot of research related to pollution. I don't want to read through the slide. Sitting is akin to smoking. Avoid sitting for more than 2 hours in one place. Standing workstations for IT people, and soleus push-ups. Actually, if you can do that, soleus muscle can be used. Even in our clinics, whenever we remember, push up the soleus while sitting, then you are working out the bigger muscle of the body. So it will help you do other things. So sitting is akin to smoking. Even for us as doctors, move around after half an hour. Take a walk, 15 steps takes about 8 seconds. So you can definitely have that much time. Periodontitis, this young man, 36 years old, farmer from North Maharashtra, very wiry, hard-working fellow, triple vessel disease, had to go for surgery. Nothing else, no diabetes, no tobacco, nothing, but just periodontitis. There is evidence related to that I just want to skip and go forward. Frailty is definitely something which we must remember now. A typically frail looking man like this has lost all his, shall we say, pad of fat here and starts looking frail. And the biggest part of the frailty is sarcopenia. they lose muscle, and that's why they become frail, and then they fall down and they develop myocardial infarction, strokes, and other. Totally preventable, totally preventable. And you know what's the first step for preventing frailty? Eating a meal every day with the family. This comes from scientific books. It's not my own creation. So all that you have to do is include them in the family. Don't make them a recluse or don't relegate them to one room. I think that will prevent frailty. Avoid large dose of statins in them. You are already a sarcopenic patient. So be practical about these patients. Feed them well. In fact, saturated fat needs to be given to these people when they are getting frail. Heart rate and mortality in healthy men, you can see that lower is the heart rate, better is the mortality. I don't know how these studies are conducted. Look at this study, Netherlands apparently. Resting and exercise heart rate measured in 5,000 men were suspected to have CVD. Follow-up was 23 years. And we finished this slide in 5 seconds and 10 seconds, but huge research which goes on. But please pay a thought for this. Reduce the heart rate, your own heart rate. And I don't know whether beta blockers reducing heart rate helps the patient or not. But naturally reducing will help. That is by way of meditation, yoga, and other things which have been discussing a lot. Aerobic exercise, yoga, meditation, mind management, and maybe beta blockers are important. Now, primary prevention obviously has cardiovascular health benefits, followed for at least 50 years of age. And clearly it is a better prevention. Somebody undergoes a primary prevention is much better off compared to those who do not follow this. The longer survival, more than 11 years in men and more than 8 years in women, if you give them good primary prevention. Heart healthy diet, lot of controversies related to that. But I want you to read this extra reading in this slide. It was JACC 2017, and this is from the American Heart Association, and it gives very clearly harm borderline recommended, and add to it Indian masala, and probably you will be giving them good diet for your own patients and for yourself also. It says that plant proteins are the best amongst the proteins. Combination of aerobic and resistance training is required. I'm showing my photograph not because of showing off, but I could only find this one. So it means that you are keeping your muscles intact. Keeping your muscles intact makes a lot of difference to overall health, especially the degenerative diseases which come later. So drugs for primary prevention, secondary prevention, here. Statins, combination of bempedoic acid, ezetimibe. Suppose somebody's LDL levels are 145, 150, and he is a 45-year-old. Then what do? I think you have to reduce that LDL level to below 100. And suppose he is a metabolic syndrome type of a person, then my choice becomes a bempedoic acid because it is sugar neutral. So rather than starting a statin, I would start, if you find bempedoic acid is not powerful enough, add ezetimibe to it. But reduce the LDL and probably you will get that. And my also dream or something is that something like inclisiran would be used for primary prevention. One injection and then it is done if it becomes cheap enough. CKD has to be used for SGLT2 is a must because it prevents CKD. And patients who are adherent to low risk, suppose, look at this. Somebody who is less than 40% medicines and more than 80% medicine, the difference in the CV events is more than 50%. So those who are adherent to your medicines are likely to be better off as compared to cardiovascular events. We are again talking primary prevention. So in fact, non-adherence is considered a new risk factor in the atherosclerotic disease. So that's why this somebody called N.J. Wald came with the hypothesis of polypill. He said that, okay, so many aspirin and other things are ramipril, they're reducing the events so much. Why not combine them? Hypothetically, it will lead to 80% prevention of primary events. So that's why the concept of polypill came into picture. I do that. Like suppose he's a villager, a farmer comes to me, he's hypertensive, tobacco is his way of life, and he's non-exercise, he's just working in the fields. If I give him 4 drugs, this, that, he's not going to take it. So I still stick to our old polypill, which little inferior in management, but it works for him because it is giving him good amount of primary prevention. Another non-scientific slide, but this is from the WHO. It is a 75 years of follow-up. 4 research teams died during this follow-up, because how many research teams will continue for 75 years? And then they say for staying alive, health, length, quality of diet depends on the social circle and connection and secure close relationship. Look at the top. Social connections and secure close relationship matter, not your exercise, not your hypertension treatment, nothing else matters much. So it's not something which you can say non-scientific. It's a huge study. So epidemiological, that's why we feel, okay, it's not very scientific. But that's why I feel WhatsApp group are a great thing. Our own old school mates, now we meet after 25 years or 30 years, and we have a gala time throughout the day. So it makes a difference if you have a large social circle, and of course the very close emotional family and friends type of a circle. So the social requirements that are required for primary prevention are increasing physical activity, yoga, meditation, strengthen the tobacco control strategies, improve dietary choices, simplified screening procedures of risk factors, and fixed dose combinations for compliance of many. Home BP measurements must be encouraged because it makes a lot of difference in good management of hypertension. So ideal parameters for health and vascular disease are enlisted. I think you know all of them. So secondary prevention importance is well known. It is somebody who has established cardiovascular disease. So in 2025, I think total cholesterol has lost its importance. Then HDL has lost its importance. Triglyceride maybe, but it is the star is the LDL. You have to, our own one target is LDL and LDL and LDL. If you aim at that and reduce it to low levels in high risk people, you follow the LAI guidelines maybe, and you will find that you will do justice to your patient. And we know that lowest is the best is where we have come now. Very high risk people less than 30, and most ASCVD less than 70 is what we think of. The chronic coronary syndrome is a terminology which was coined in the European Society, and almost 33% of coronary syndromes are in our own practice now, not acute coronary syndrome. So how are they managed? They are managed by preventing events. Actually, it is nothing but prevention of events, that is secondary prevention. And there are some other trials which also support this kind of conservative management for chronic stable disease. The guidelines are completely different. Suppose somebody has an 80% lesion in the right coronary artery, acute coronary syndrome, no doubt you have to stent it. Chronic coronary syndrome, you may have to wait and treat him on medical treatment. So that's kind of a difference is possible. Because chronic coronary syndrome, if you leave on good medical treatment, there is about 5%, 6% chance of getting an event in 1 year. And if you put one stent, the risk level is also so much. So it's not a great difference except for symptomatic management. So if we look at these ACC management of stable ischemic heart disease, most of the things are known. So it is said that it is the most preventable disease. One of the most preventable diseases is the cancer which happens because of smoking. So if you don't smoke, you don't get that cancer. But the second most preventable disease is second heart attack. So if you really work on your patients, then you can be a winner by preventing him his hospitalization, expenses, and so many other things. So the COMPASS trial thought that why not in these patients give rivaroxaban instead of the second antiplatelet agent, which was anyway overused. So if you have somebody who has 65 and above, diabetic, ASCVD, polyvascular disease, that means he has coronary disease, carotid disease, peripheral artery disease, this probably makes a case for rivaroxaban vascular dose, 2.5 milligrams twice a day, but it has not appeared in the guidelines. So I would leave to that only this kind of a subset where one could use, but otherwise I will wait for some more time. So I feel monoclonal antibodies and other things have to be used because there is a reduction of almost 60% reduction in LDL on top of a statin therapy. Such a whopping reduction is not possible with drugs which can cause side effects, and the frequency of inclisiran is also very little. So slowly the use of these things will go on as time goes by. The official winner of Not My Job contest, this man was given a job of painting the side of the road. And because this tree bark was here, he painted around it, saying that it's not my job. So treating coronary artery disease is like that. If you don't prevent, you will get an official winner for this kind of a job. This whole thought process started by Dean Ornish. If you read the book, it is highly unscientific to start with, but the principle is correct. Good lifestyle, it can prevent, is what it says. And then it appeared in the American Journal of Medicine way back in 1998 about non-invasive management and reversal. So I'll just be wondering, and just only 10 seconds to go. So if you have, what is reversal of coronary artery disease? If there is no stenosis, hypothetically blood comes here and comes out of 5 lines. 50% stenosis, no change in flow. 75% change, no stenosis. But at a critical juncture from 75 to 80, suddenly there is flow limitation, incidences, angina and other things. So if you reverse from 80 to 75, suddenly you will get more flow. Your stress thalliums will be normal. So this kind of a reversal, mini reversal, makes a huge difference because the flow dynamics is such that flow is dependent on the 4th power of the diameter. So if you increase the diameter a little bit, it will help a lot. I think I'll go to the last slide now. Okay, from birth to natural death, if you draw a line, a triple vessel disease leads to premature death, but a good maybe bypass surgery brings him back. A double vessel disease leading to premature death, a good angioplasty does that. Let the interventionalists and cardiac surgeons do this part. It is a major change in a small community. But what we have to do as clinicians is prevention and prevention and prevention. You follow the principles, patient will go to his natural death without undergoing any other things. Thank you.
Thank you, sir.
Excellent talk as always, Dr. Hiramat. I think the session is open for questions, comments. I'm very sure there'll be many points and questions.
I thought keynote address, there were no questions.
Of late, we have come across so many cases or increased incidences of sudden young cardiac death.
Next talk. I think leave it to Dr. Yashlokan. Next talk.
So, do you recommend, you say that prevalent hypercholesterolemia can go ahead with 27. What about primary prevention? Still go ahead with that, or?
See, all the inclisiran evolocumab trials are in secondary prevention. There is no evidence. But my, shall we say, utopic view of turning the tide, it's not there, is where you should have a genetic mix, and a time will come when we'll give you one injection for 6 months, and then will be no medicines, nothing. So that will work for primary prevention if there is some more research. If primary prevention is going to come through LDL reduction, why not? Logically, it seems okay. And the frequency is once in 6 months. I think it will add a lot of to the thing. So primary prevention also would be possible, but one would wait for evidence to come. Actually, I got your question. CT coronary angio or calcium score has to be used much more than what we are using today. I'll give you one example. A 50-year-old undergoes an executive checkup. His LDL, this sense, everything is normal, and his stress test is negative. So what do? You leave him on nothing, no aspirin, no statin, nothing. And after 1 year, he comes back with a myocardial infarction because he had a 50% lesion and he had a calcium score of 58, 59. And because you did not give him secondary prevention, he can get into an event. So our thinking should be to do anatomical thinking first. Get the CT angio done first. Suppose the CT angio is clean, then it's a difference. Suppose the CT angio shows mild disease, some calcium, put them on secondary prevention and then follow them up with hemodynamic testing. That means every year, suppose he does a stress test. If it is normal, that means we know that the block hasn't worsened. So that is how we should, in the hierarchy now, CT angio has gone higher up. It could be the first one to look at coronary arteries. I don't differentiate. In our center, everything is the same. CT angio and CT, everything is done at one go. I don't have very little difference.
Thank you, sir, for some eye-opening facts that you gave just now. I wanted to know your experience about PCSK9 inhibitors. Last 1 year, have you used, and or any other cardiologist here? How is the experience?
It's phenomenal. I mean, there is just no doubt about the efficacy of the drug. Indian patients, inclisiran and evolocumab, we have been using very often. And the results are dramatic. We've had patients with LDL of 10 and other things. So we don't want to be 10, but it can happen that it is so powerful that it can do that. So there is practically no side effects. Practically except for injection site thing, there is nothing at all. So if somebody can afford it right now, I'm inclined to use it rather than not use it. Yes, sir.
Yeah,
No, of course, basic statin will be there.
just adding one point to what he said is, see, the values of LDL cholesterol and non-HDL cholesterol to be brought down for secondary preventions are so low now. Say we are talking about 30, and that really works. So reaching to 30 LDL is next to impossible in more than 50% patients with whatever oral medications you take. So many of my patients are on fullest dose of statin, ezetimibe, and bempedoic, all three together, and still they are having 65, 70. So there is a huge need of this molecule. There are many patients of mine at my institute who are on inclisiran. Unfortunately, though the previous drug, PCSK9 monoclonal antibodies, have got good data in secondary prevention even of CVOT, but since it's twice a month and the cost is little higher, many of my patients have been now placed to inclisiran. It's a wonderful molecule, almost devoid of any side effect, and it has amazing power and potential to reduce a huge burden of events and interventions.
Just like the Ernie talk, you can't give 80 milligrams of atorvastatin in everyone, 40 milligrams. They may not be tolerating at all. So in those cases also, I'm resorting to.
Dr. Anish, in those patients, you stop statins and rest of the things,
No,
right?
no.
You continue the
You cannot,
best things.
because see, statins are 35 years old drugs. They are Amitabh Bachchan, extremely proven, and they have to be used. This is on top of that.
Yes.
So best possible dose which is tolerated by patient of statin should be used.
You attain the goal and you have a powerful thing to attain.
Sir, excellent talk. And the summary and the take-home message from your talk is that target LDL only. The villain of the talk is LDL only. So my question is, irrespective of the age, irrespective of the patient having existing comorbidity or some other metabolic issues or not, see, can we approach as a clinician of all LDL above 140 or 135 by medical treatment besides lifestyle modifications?
Yeah, suppose somebody doesn't have a big risk, then we have to bring them down to 100. Average Indian adult should have a LDL value of 100. And those who are ASCVD can come down to 55, and those are very high risk 30. So as you said, yes, suppose you are treating somebody and the LDL value is more than 145 persistently, then I would use statin to bring it down to 100. Use LAI guidelines. I think they're good guidelines.
Yeah, but sir, what we observe that in spite of aggressive exercise or regular walking, stability of the weight and all that,
It doesn't
we
happen.
have observed that LDL remain around 135, 40. So
You have
can
to
we
use
give
a
a statin
statin.
in that group of patients?
Absolutely.
Just for primary prevention?
No doubt. No doubt.
Even
As-
though the coronary calcium score is zero.
Zero, yes. Primary prevention now, statin has gone ahead of aspirin.
So the conclusive remark is that irrespective of even calcium score is zero, patient is doing active lifestyle and controlling everything, even though LDL is persistent 140, we should give statin.
So just adding one point to that is, see, LDL cholesterol is modifiable by 15 to 20% tune whatever you do. Somebody doing fasting also and exercising 5 hours a day, LDL is not modifiable by more than 15 to 20%. Now, this is most important concept, which we need to talk to the patients, number one. Number two, the concept of exposure of LDL years has become so much valid and practically relevant that somebody, say for example, in spite of doing everything and having calcium score 0, but having LDL of 135, 140, if he is exposed to that level of LDL, sooner or later, he or she is going to have atherosclerosis and events. So in India, if you want to attack, I personally believe everybody in my life, latest by the age of 15 years, lipid profile with lipoprotein A must have been done. No Indian should be left alone without lipid profile lipoprotein A by the age of 15 years, because you will find 5 to 10% people even in that zone whose levels are very bad, either lipoprotein A or cholesterol. Maybe see at that stage you may not start medicine at stage 1, but then you can be conscious on lifestyle, and those are the people who are to be followed rigorously. And early institution of lipid lowering therapy is a must.
And
Dr. Anis
that-
has already made the point of LPA. Sir, all these drugs, statins, and they do not lower the LPA. So probably that is where inclisiran and PCSK would have a role.
LPA is still an enigma. That means by lowering LPA, whether you make good benefit to the patient or not, we don't know. But it definitely gives you a genetic propensity of that individual to develop atherosclerosis. So it is said that you do LPA at least once in lifetime. Once you do that, and if it is normal, then don't repeat it. But if it is high, then your aim is to reduce LDL to the desired levels, whether it requires a statin or not.
Maybe adding 1 or 2 points to that. Lipoprotein A is a risk multiplier. So when you calculate risk by other parameters, and if lipoprotein A is less than 30, the risk calculated is okay. But if lipoprotein A is high, it multiplies the risk by 1.5 to 3 times, number 1. Number 2, inclisiran does reduce lipoprotein A, but to have any meaningful, as far as cardiovascular event is concerned, we need to reduce LPA by 80 to 100%. So inclisiran reduces LPA by 20 to 30%. So that's why even monoclonal antibodies, they say that all the benefits are purely because of LDL cholesterol reduction, and you should not extrapolate that it is because of lipo-A. There are multiple trials with injectable and one with oral medicines going on. By 2026, we'll have trials of medicines and injections which are reducing lipoprotein A by 80 to 90%, whether they reduce CVOT or not. Till then, a wonderful thing about if you live a lifestyle where Dr. Hiremat talked, and I know that many people live that way, you reduce the impact of lipoprotein A on your cardiovascular risk. And secondly, even if your LDL is normal and blood pressure is normal, you reduce your LDL by 40 to 60 milligram, whatever the level is. Suppose your LDL is 80, bring it down to 40 and reduce your blood pressure by 10 millimeter of mercury, irrespective of blood pressure is, if you can tolerate. It can reduce and eliminate the factor of lipoprotein A risk. So till we get a medicine, we have these 2 measures.
The last question. Irrespective of the LDL value, can we give statin to all the patient above age of 50?
No, if it is not, if
primary
it is
prevention,
if it is around 100, why do you want to give it?
there is no benefit.
Thank you, everyone. I would request Dr. Devang Shah to felicitate our honorable speaker. Dr. Devang Shah. Team, please go on the stage with memento. I would request Dr. Jay Shah to felicitate our chairpersons. Dr. Jay Shah, please come on the dais. Would request Dr. Neerav Shah to come on the dais, please. Dr. Neerav Shah, please felicitate our experts. Dr. Neerav Shah, please felicitate Dr. Mayur Shah. Dr. M. Syed. Thank you, the chairpersons and experts. For the next session, I would request to chair the session Dr. Urman Dhruv. Please come on the dais. Dr. Urman Dhruv, sir. Dr. Mahadev Desai. Dr. Jitendra Patel. Dr. Jitendra Patel, please come on the dais. Dr. Kirit Akhani. And experts for the same sessions are Dr. Sushruth Kanungo, Dr. Bhavesh Jarwani, Dr. Falguni Vora, and Dr. Shilpa Doshniwal. Dr. Sushruth Kanungu, sir.
After wonderful sessions about the heart failure and the prevention, we are now entering to a totally new era, and that is where every conference probably would not be complete without talking about artificial intelligence. And we cannot have a better person than Dr. C.K. Pandey, whom I am sure everyone knows, and he's going to talk about artificial intelligence in cardiovascular medicine, the good, the bad, and the ugly. And it's over to you, Dr. Pandey, sir.
Thank you very much indeed. It's a real pleasure to be here. This at the outset, I might just add here or say, when Jay called me saying that, sir, this is a topic that we are giving you, and I went through other topics of the conference. I said, let me talk something completely offbeat, and I have been doing this for the last 4.5 years very intensely since 2019. I thought I will share that with you. So, my talk today is artificial intelligence in cardiovascular medicine, the good, the bad, and the ugly. My first question to all of you all is, how many of you, by the way, how many of you are students here? Fantastic. Fantastic. Why the students are sitting back at the back? Please come forward. Please, there are so many chairs vacant here. Come forward. Because it's going to be a roller coaster ride. So, the way you board the flight, they say, sit back, enjoy and relax. Relax and enjoy the ride. I would not tell you to sit back. Sit at the edge of the seat, because that is going to make you enjoy this talk. All right, so what is artificial intelligence? Artificial intelligence is the process of unifying mind and machine through human brain and computer interfaces. The term was first coined by John McCarthy in a conference on science and engineering of making intelligent machines way back in 1956. So in healthcare, it all is about unifying human mind and machines. In other words, the theory and development of computer systems which are able to perform tasks that normally require human intelligence, such as visual perception, analyzing histopathology images or X-rays or angiograms, speech recognition, decision making, and translation between languages for the layman, but also to do tasks beyond human intelligence. And there, Elon Musk just said 6 weeks ago, scientists have got only 10% chance of making artificial intelligence safe. So we are there heading towards a target which could be quite dark and ugly at the end of the day. And this is a photograph of a 18th century physician, who used to sit by the bedside of an ailing patient. They will observe the patient for hours. The breathing pattern, the pallor on the face, the pulse, they would even smell the breath to get to the diagnosis. And you see here, you are not seeing this man, all right? This man was an assistant, staying in the shadows and watching the patient from another angle, just in case the physician misses some observations. Just like Sherlock Holmes had Watson, right? Same way. Now, we are replacing that assistant with artificial intelligence. And that is how it could be. So, the fathers of AI are Marvin Minsky and John McCarthy. If you ever read the first article of Marvin Minsky in a 1976 journal, you would be amazed to see this guy's foresight into future. I think those are the guys which we call visionary. We are just hard workers. We just cannot even use the existing knowledge properly. These were visionaries. So, artificial intelligence is any technique that allows computer systems to mimic human brain. What is machine learning? A subset of AI that uses statistical techniques to enable machines to learn from data. When in 1918, I started taking interest in this field, and suddenly I came to know one of my pediatrics friend who is working in Muscat now, my classmate. His daughter, after doing MBBS from Andhra, told his dad, because of you I did MBBS, I've never wanted to do that, but now I'm going to do what I want to do. And she entered this field. Her name is Sindhu, I contacted her, and when she came first on the Zoom, for the first 10 minutes, I thought an alien is talking to me. I couldn't fathom anything. Everything went tangent, And she said, "Uncle," because she was so small when we were in MBBS. So she said, "Uncle, I think you are getting lost. Please don't. You are a doctor, and what I'm talking to you is from parallel universe." These were the two words which took me off my seat. She said, "There's a parallel universe out there, uncle, and that is happening. And no matter whether you like, whether you don't like, whether you hate, whether you like, whatever, you will have to be with it." And she said, just another decade and doctors will be classified into two. Doctors who are with AI and who don't know AI at all. That's about it. So, supervised learning is where AI is today. Machines learn explicitly. We give machine a labeled data with clearly defined inputs. I will show you some examples of that. And then resolve classifications and regression problems. So unsupervised learning is where some of the algorithms have already reached. One EP algorithm which Yash will clarify in his talk about sudden death prediction from a surface ECG done 20 years ago. That is called unsupervised learning. And reinforcement learning, where machine learns how to act in certain environment without you ever having trained that machine to react. The machine will act. All right. So that is something. See, for example, supervised learning has 5 facets, and it took me almost 3 months to understand what does this mean. But I request you not to go in details of that, but just to clarify, artificial neural network, support vector machines, which we are using in ecos now, fuzzy logic, which is used in electrophysiology and cath labs, and K nearest neighbor, KNN, which is used for epidemiological population-based models to produce or to predict all-cause mortality and disease patterns. Now, what is good? Do we really need AI in cardiology? Yes. Cardiology practice is becoming more and more complex. It is becoming hard to properly make sense of all data and face the workload of human modern medicine. Humans take images as a series of photons in their retina and pursue them through visual system. Haven't you seen a single angiogram recorded as 50% lesion by one cardiologist, 70 by the second, and 90 by the third? Haven't you? Right. That is human perception, and some information is invariably lost in this process. AI models can directly pursue raw data as they are with phenomenal speed and accuracy, which has the potential to minimize bias, data loss, and noise. It has phenomenal accuracy. I'll show you some clips of that. By combining different inputs of data and different processing methods, then AI can see an ECG like no one has seen before. No human has seen before. Mildest of the deflections in the P wave amplitude, P wave breadth, the negative component of P wave in V1, its width and its depth, the way AI can analyze, humans can't. Just can't. We don't have that ability. And then the AI can integrate that when a lot of data is fed over a period of years along with the echo data to predict whether this man is likely to develop ejection fraction poor over 10 years follow. I will show you some. So the good part is natural history of the disease. Metabolic and physiological abnormalities take over years. You are asymptomatic, you feel great, and then symptoms and signs develop. But by that time, it could be too late because the first symptom could be stroke, heart attack, or even death. Is ejection fraction low? So a single heart cell is important for myocardial contraction. It is also important that it gives an electrical voltage on the surface ECG. And then the ECG recorded from body surface. This is widely available, inexpensive, painless test. But when you feed hundreds and thousands of echocardiograms of thousands of patients, followed up for 10, 15, 20 years, and their simultaneous good quality echocardiograms over a period of time, you form an algorithm. One such algorithm was formed by Sindhu and is now patented by Mayo Clinic. And I will show you what does it show. The area under curve is 0.9 almost. area under curve is 0.93. What does that mean? That means a surface ECG can tell you whether this patient is likely to have a low EF or not. You will tell me, what the hell, Dr. Ponde? I have a echo machine available in the casualty. Well, in India, we are lucky. In US or UK, to get an echocardiogram appointment, it takes average 3 weeks, right? So which patient should go prioritize to be echo will be done by this ECG. And there was a prospective validation of deep learning electrocardiogram algorithm for the detection of left ventricular systolic dysfunction. Proudly again, this algorithm was completely and thoroughly conceived by Sindhu. Artificial intelligence enabled ECG algorithm to identify patients with left ventricular systolic dysfunction in the emergency room. In ER, patient comes breathless. First, what is done? ECG. Whether this ECG suggests left ventricular dysfunction or not. A phenomenal study, 18,000 patients, and what is important, AI ECG outperformed NT-proBNP. Because NT-proBNP, the downtime is 3.5 hours. You send a sample, you get a result, minimum 3.5 hours in the best of the lab. Even my lab takes 3 hours. Examples. 35-year-old asymptomatic man presents after his sister dies suddenly. And therefore he thought he'll get his ECG done. What do you think about the ECG? Looks quite okay, right? It looks normal. But the AI ECG said this patient has 76% probability of having low EF. Patient went for echocardiogram, ejection fraction was 18%. Diagnosis, familial dilated cardiomyopathy, phospholamban C. Right? Next patient, 28-year-old male. Look at the ECG. V2, V3 shows biphasic T waves. Something like maybe ACS, but this patient had not come for chest pain. This patient was come for a perfectly normal health checkup. AI ECG was positive for low EF. Patient was sent for an echo, but the echo showed normal, near normal EF, 50%. So the AI ECG was false positive for low EF, right? But 5 years later, the same guy develops ejection fraction of 31%. Then Friedman, Jashi Etia, and Patricia Pellica, these are the 3 big guys in AI. They collected all this humongous data. And look at this. These light green bars are patients in whom the AI ECG shows low EF. Index time, the patient doesn't have low EF. But over 12 years, almost 1/3 develop low EF. As against, when the AI ECG shows normal EF, only 10% develop poor EF over 12 years of follow-up. What does this mean? This means that a single myocardial cell voltage that is expressed on the surface ECG, if analyzed in a specific manner with humongous amount of data, can predict a patient developing left ventricular dysfunction over 10-year follow-up with an accuracy of 0.93, almost 100%. All right. Going ahead, when this was adopted clinically in a primary care model, people or patients or physicians who adopted AI ECG were 3 times more likely to detect left ventricular dysfunction as compared to those who did not adopt. Now, can that be scalable to an Apple Watch or a Galaxy Watch? Not a 12-lead ECG, just an Apple Watch ECG. So a great study was done by, again, Attia, Harman, and Dugan on prospective evaluation of smartwatch enabled detection of left ventricular systolic dysfunction. 18,000 patients and odd. An AI algorithm detected patients with low EF with an area under curve of 0.9. Right? So, but you need a longer recording. You need a recording of 3 minutes. So every volunteer gave a 3-minute recording of smartwatch ECG, not 12-lead also, not 12-lead. Yet it could detect left ventricular systolic dysfunction. And then a randomized trial. The Eagle trial, which you all know, was close to 22,000 patients over 8 months, 120 care teams, and AI was effective in diagnosing EF lesser than 35%. Now, where are we going? In Hinduja, 4 months ago, we started a trial with a ELEPT program. It is echo for left ventricular systolic dysfunction, but it's not only, echo is the company, not echo. There is a stethoscope which you put on the patient's chest. It records the phonocardiogram, that means heart sounds. Simultaneously, you put this on the chest, it records 2 lead ECG, that's it. 1 and 2 and 1 and AVF. So right arm and left leg and right arm and left arm, just 2 leads. 2 limb leads and a phonocardiogram, and that can detect left ventricular systolic dysfunction. So we are planning to study 1,600 patients. We have finished around 370 so far. Let's see. Can clinical practice be modified because of this? Yes. Countries where echos are not available at the drop of a hat, it can be. Can ECG predict biological age? Now, Dr. Hiremat just said, social isolation makes you physiologically older. Married people live longer, whether the marriage works or not, irrespective. Whether you fight or kill each other, yet you live longer. So, acute illness makes you physiologically older. Obesity makes you physiologically older. Biomarkers of biological age, we all know. And the biggest biomarker which has come in the last 10 years is cystatin C. Cystatin C has outperformed all the other biomarkers for older age. And of course, lamine AC deficiency. We know that lamine AC is a protein which maintains structural integrity of the cell nucleus. It regulates gene transcription, cell differentiation, epigenetic regulation, and DNA repair. And the LMCA gene encodes lamine AC. Now, are we going to do all this genetic 25 biomarkers test in every individual? No. You just do a surface ECG. Just a surface ECG. Feed it to the AI. Example, it gives you real age versus biological age difference. Area under curve, look at here, 0.97. Example, 35-year-old woman presents with a cardiovascular prevention clinic. She's 106 kgs in weight. The AI ECG says her age is 41 years. She's 35 years. So the AI ECG says she's biologically older. Metabolic syndrome patient, right? That Dr. Jagrevan just said. And the same patient undergoes another ECG a year and a half later. Now this ECG says she has now her age is 36 years, because in those 36 months she has lost 10 kgs of weight. So ECG can tell you your biological age versus your chronological age. So this one patient, again published by Friedman's group. This is the ECG age. This is the real age. He was 38. The AI ECG said he is 55. Why? Ejection fraction was 25%. Kept on going. At the age of 51, the AI ECG said his age was 62. Suddenly, at his age of 53, he had some therapy. And at his age of 55, AI ECG said he is 50. What happened? What happened? He got a transplant from a 20-year-old donor. So, that is what AI can do. Madurai Eye Institute, as you know, their pivotal work, Dr. Jayagopal must be aware, about oculomics predicting cardiovascular disease. And what they did was, in this happened in COVID pandemic actually, a paper published in 2021, they fed thousands of retinograms and the patient's history to an AI algorithm. And now a single retinogram image can tell you whether the patient has diabetes, likely to have hyperlipidemia, what is the duration of the hyperlipidemia, and even the average life expectancy. So going ahead, change can be scary. But you know what is scarier? Allowing fear to stop you from growing, evolving and progressing. Symptomatic AF, Yash is here, and you have subclinical AF, which is common, undetected and associated with stroke. And now artificial intelligence ECG can even predict patients who are likely to have AF in future. So this is a patient in whom an index ECG is taken, patients with no previous atrial fibrillation ever, and you follow them up over months. Here is the ECG of a patient who has had paroxysmal AF, and the ECG can predict that by the end of March, he probably have another episode of AF. It can tell you that. Area under curve 0.90. So AI ECG calculated AF probability almost equals to the charge AF score derived probability. So it is mind-boggling what is happening there in the parallel universe, and to the extent that even detection of left atrial myopathy using AI ECG is very, very strong. So if you see your left atrial reservoir strain, left atrial volume index can be, what is the likelihood that this patient has left atrial myopathy can be told to you by a simple surface ECG algorithm. That algorithm is called 2091C algorithm of AI ECG. Similarly, as you use these ECGs, suppose AI says probability of left atrial myopathy is 1%, the echo is almost always normal. Whereas when AI says probability of 85%, you will see dilated LA, secondary mitral regurgitation, E by E prime elevated, and pulmonary artery systolic pressure elevated. Okay, electrocardiogram can also be used for screening of aortic valve stenosis in the population. So there is an algorithm which has again been patented, now launched by Australia New Zealand group of scientists, where an ECG can tell you whether the patient is likely to have asymptomatic significant aortic stenosis. This is an old man who had a normal ECG, AI normal ECG 8 years earlier. He comes later on for a follow-up. 2016, this AI ECG shows he is likely to develop AS. And 2019, the patient has significant aortic stenosis. Echocardiogram was not done in 2016. So, for example, this is a typical echo of amyloid, the cherry on top appearance of the myocardial strain, right? And now, AI algorithm, another algorithm, this is a weird algorithm formed by a group of scientists from Latin America, which can detect amyloid from a surface ECG. Power of cardiac ultrasound. Where I come from, like my passion is echo. So let me show you some of these. A 42-year-old male smoker, and this is the Ultramix AI that we are using in our lab. He came and this was his echo. Can anyone see any abnormality in this echo? Any regional wall motion abnormality? Even the strain is here. Nothing, right? Nothing. This patient had pain. Patient was 42 years old male, smoker. Troponin was negative. We were about to send the patient home. I thought, now that the Ultramix is there, why not feed it? We feed it. Ultramix said, tight diagonal or Raymer's disease. I said, what the hell? So I told my registrar, Baba, convince him. If he gets convinced, we'll shoot his angio. And this is the angio. Can you see this tight diagonal lesion? This LED is moderate plaque, but the diagonal, high diagonal is it's a very big vessel, another tight. Now, you will ask me, what did AI see in that echo which you and me could not see? Here is
which way?
Keep going. I can direct you from here.
You both know what's at stake here. We cannot afford to lose that list.
Yes, ma'am.
You'll be wondering why I'm showing you this. more than around 250 pairs of human eyes have seen this clip. My question is, can you tell me how many persons did you see in this clip? How many cars did you see? How many cell phones? How many umbrellas? And how many ties? Can you? You can't. You just can't. And this is what AI will do. Person, 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 umbrella, cell phone, tie, person, chair. That is how it goes. So AI can analyze data you cannot even fathom or imagine. So what I'm driving point at is diagnosis of prostatic cancer, diagnosis of Barrett's esophagus on gastroscopy, I mean upper GI endoscopy, has been enhanced phenomenally when AI tools are used. This is a typical echo of an amyloid, right? You see this echo like this. Look at my ultramic AI in my lab. How does it see? I'm sorry. Can I go for 2 minutes? This is how the AI will see that clip. It will show as multiple numbers of grayscales. And you will know that the apex has 0 grayscale, absolutely 0. So you will know that there is something wrong at the apex. This is how the AI will see. So there are a few AI-driven algorithms. You just acquire a parasternal long axis view and just put one click, and you will get the dimension in systole and diastole. Same way, you take a mitral inflow, get 5 or 6 beats, and previously we used to do E wave, A wave, E wave, A wave, etc. Now one click and you are average with everything. 2-dimensional echo, same news. 3-dimensional echo, just one view, give one clip, one command, and this is what AI, this is automatic. The AI is doing, this is Ultramics AI. There are so many other AIs available, but G uses Ultramics the best, and you get a 3-dimensional ejection fraction very easily. RV ejection fraction, same way. Quantification MR, again, the support vector machine uses this and can classify MR as mild, moderate, severe with just 2 views. You don't have to do anything. Parasternal long axis, apical phone chamber, keep the color Nyquist at 70, record 5 cardiac cycles. It will tell you whether the MR is likely to be severe or not, right? Even for detection of AS, the algorithms are already developed, and therefore AI-enabled echo is now in place. I am using Ultramics for the last 3 years, and I can tell you that we wrote our first paper 1.5 years back about reduction of time consumed per examination, close to around 8 to 10 minutes per examination by using AI. Constrictive pericarditis versus restrictive cardiomyopathy, right? This is the commonest question for cardiology. Now an AI algorithm is in place to separate that. Similarly, artificial intelligence and echocardiography is a very, very happening thing right now. It is available even at this moment. Now, for example, does this patient have HPEP? Can you tell by one view? Impossible, right? You have to get E by E prime, lateral E prime, E by A ratio, etc., etc. But now, Ultramics can give by one view. Likelihood of this patient having HPEP or no. So, right from classification of the images, optimization of images, volume calculations, and identification of cardiac diseases, now AI is going to come in a big way. Can it replace an echocardiographer? Well, time will tell. AI in cath lab from pre-intervention, intervention to post-intervention. And this is one study done in 13,000 patients between 2010 and 19, training AI algorithms for detection of vascular stenosis, right? And see here, it can detect with the accuracy of almost 90%. So those visual things, I feel this stenosis is 70%, can be always double checked with AI. Similarly, AI can localize stenosis and predict severity, sets the foundation of standardized stenosis. Another important thing in cath lab is to identify whether a given stenosis is severe or not by FFR. We do FFR. Now we can do virtual FFR and we can do the, for example, this contractility appears less, this contractility appears more of the heart, right? This can again be told by AI in a fraction of a second that this patient is likely to have very poor ejection fraction. Similarly, going ahead, the QFR and the VFFR is now a reality in 2 labs in the country. One is Dr. Ashok Sid's lab, a reality, and second is Dr. Ajit's lab in MMM. They are just buying, they are in the process of buying the AI. So the application of AI in cardiovascular CT is also phenomenally increasing. So cardiac CT now, CT angio, can tell you the virtual histology of the artery using AI. The algorithm is not yet patented, not yet US FDA approved, but I can promise and tell you in 2 years it will be. So a future cardiologist will look like this. He will sit in the console. AI robot could perform most of the interventions, voice assisted commands, and clinical decision support system, and a virtual hologram to diagnose or to get into the place where you want to be, particularly with for the EP studies. So this is going to come maybe not 5 years, but 9 to 10 years. Did you know ChatGPT takes the European exam core cardiology? And it passed with brilliant marks. So that is going to happen. But investment in artificial intelligence have crossed millions and millions of dollars. So if you think that AI is going to die off, it is one of those things, yaar, ye aisa hi aayega, chala jayega, nahi chala jayega. Because the money invested is humongous and those guys are not going to sit tight. So currently we are somewhere here, then there will be mass adoption, and then there will be maturation. Microsoft to buy AI firm for $16 billion, 2021. $16 billion. The bad, AI cannot reason out, okay? AI have no reasoning, which only human minds have. AI cannot do reasoning. Yes, that's a problem. Second problem, AI will have bias. Why bias? Because AI depends on the data that you feed. If you feed male data, and apply it to the female patient, it will go wrong. So the data has to be gender neutral. So it cannot be like randomized trial where 70% are males and 30% are females. No, 50-50. Then only an AI algorithm can succeed. Ugly, AI depends on data. And these companies which are invested millions of dollars in data, just like Facebook, Instagram, and that all that stupid companies, they will buy and sell this data. That is the fear. And patients' confidentiality may be lost. So we started in 2017, and these are the milestones in the AI. Scientists only have 20% of chance of making AI safe, because when the AI crosses the stage of unsupervised learning, what could be the next step will be anybody's guess. I suspect that ethical concerns are there, but the potential of artificial intelligence for making healthcare better is indisputable. The question is how to integrate successfully in our healthcare systems. For doing so, we have to overcome technical limitations, regulatory obstacles, and curb the tendency to oversell the technology. So we need to stay with AI and use AI in a very clever manner. The biggest fear with so many of the students there will have, will AI replace medical professionals, right? Now, to answer this question, do you know who is this? She's Maika. She is the CEO of a Polish beverage company, Dictador. She is a humanoid robot. August 2024, Dictador, a Polish rum company, appointed Micah, a humanoid robot, as its official CEO. And she has outperformed all the previous 6 CEOs in less than 9 months so far. Go on the Google and check. You will have her interviews, and in a Reuters video interview, which is there on the net, Micah says she operates timelessly 24/7, working 7 days a week. She says, I don't have weekends. I'm always 24/7, ready to make executive decisions and stir up some AI magic. So whether robots will replace us, time will tell. But because AIs don't have consciousness, they can't reason out. Neither man nor machine can replace its creator. And I take a breath at that, and thank you very much for listening.
I think we all need to give really a standing ovation for taking us to a really wonderful journey.
Excellent.
I was born in 1959, and I believe I have mixed feelings today. One is I'm happy that I got born in 1959 so that I don't have to chase all these things, and unhappy because I believe that I would not be able to see much of AI. But the question to you is obviously whether AI is going to replace doctors or not is a different thing. But as a postgraduate teacher, after seeing such wonderful presentation and information and evidences, how do I convince myself to explain to my students that they should look for murmurs and thrills and whatnot?
Yes, the science evolves, as we all know, and we all evolve from one phase to another. Like, for example, I remember when 1993, when I was doing a lecturer post in JJ Hospital in cardiology, my parents used to be in Sholapur, and to give them a call, I used to stand in the STD booths queue after 10 p.m. because the rates used to be quarter rates. And at that time, if somebody would have said that when you are 60, you will be able to talk somebody from US with a video call, looking at his face, I would have said, are you mad? So things have happened, right? Now today, your Sabjiwala has a mobile phone and a WhatsApp. And when you call him, in Mumbai at least, they say, बहन जी कुछ चिंता मत करो, मैं pictures भेजता हूँ, ये available है, आप tick mark करो, मैं भेज देता हूँ. That's it. So science is going to evolve, and I feel that youngsters in particular, I insist, I don't even recommend, I insist that you must do a 3-month or 4-month online course of AI. I have done 3 of them, and it is mind-boggling. And that is going to be the future, whether you like it or not, because the parallel universe has gone far ahead. If you know that quantum computers are coming in next 3 years, and if you read on the net about what is quantum computing, you will realize that parallel universe has gone far too ahead of where you and me today are. So it is better to bridge the gap as early as possible, I think.
Now,
we can. See, no, I agree. So when that is what, when I spoke to Sindhu for the first time in the Zoom meeting, I you know what, she looked at me with lot of pity in her eyes, pity. And she said, uncle, take a breath. You are not ready for it. I will send you some articles. Please go through it. Then she sent me some lectures of hers. And then slowly, I started realizing what is machine learning, right? It took me 3 months to understand what is deep learning. And unfortunately, we don't have the mindset. We doctors don't have mindset to go there. But now that tsunami is coming any which way, it is better to understand what it is. It is better to utilize it to your good. And then in 2021, I told my institute to buy Ultramics AI for our GE machines, and it is wonderful. I can tell you that. The echo image that the AI analyzed and said it is a high diagonal lesion, I would have missed. I would have sent the patient home, right? So one must understand that there are limitations of clinical examination and clinical skills. There are some limitations which you can bridge with add-on image, just the way we have bridged with CT, MRI and things like that. This could be an added tool to help you. Don't get scared of it. I think you have to move ahead with hands in hand. Thank you.
Thank you, sir.
Yeah.
So, subsequently, I feel we will have all the ECG and echo machines with AI in it. Maybe somewhere 5 years down.
Yes.
So, if a baseline ECG with the AI says, even if we feel it's normal, says that this patient will develop heart failure maybe in 3 years, 5 years, or 10 years, with the way you showed us. So, will we be intervening then?
No.
Or it would create such an
The
anxiety
intervening,
to the patient.
that intervening will be at the level of Dr. Jagdish Hiremet's intervention
Prevention.
called primary prevention, could be even primordial. Suppose that guy is obese.
Then
You
that-
tell them to reduce weight. If the HbA1c is borderline, pre-diabetic,
You can do the prevention part.
Absolutely.
But it could create a lot of anxiety also to the patient.
Probably yes. Probably yes.
Field of AI.
Dr. Kanugo wants to ask one
Sorry.
question. Dr. Kanugo. Sir, please go ahead.
Yes.
A simple question. In a field like psychiatry, can AI take over?
I don't think so. No, I don't think so. Yes, this is very important.
So that's why I insisted my daughter to take up psychiatry as a
Perfect.
postgraduate.
Now, so I'll tell you one annotation to that is that Dr. Hiremet showed in his slide what are level of evidence 1B, 1C, 1D like that. For clinical psychology and psychiatry, they are extremely difficult branches for the simple reason that human mind is extremely difficult. Extremely difficult. If you have a sound mind, you cannot ask anything else from God. And if you have a sound body and healthy body, probably nothing, you have no right to ask anything else. So I agree with that. Thank you.
Field of AI has, yeah.
As therapists, we will be replaced because of AI.
No, I don't think we'll be replaced. Very frankly, I really don't think we'll be replaced. Our roles will change. Our roles will change. And our roles will be, perhaps we'll get more time to spend with the patient. That is how I look at it, positively. Right now, how many minutes you can give per patient, right? Now, all that mundane jobs will be done by AI. Data preservation, medical records, writing forms, summaries, etc. Everything will be done by AI. Even to the point that when a patient arrives in the emergency room, even if a completely illiterate guy sitting as a medical officer, he feeds the data, you'll get the diagnosis. There are two softwares like this. Isabel, Yash knows. Joseph Brito, you know, Yash, from JJ. Rajani's classmate. So he is the pioneer of Isabel as a software, which is now approved by the NHS in UK. You keep on feeding the data. 70-year-old man, acute onset breathlessness, BP 210 by 110. It keeps on saying hypertension, heart failure, rule out aortic dissection, rule out this. It just keeps on. So what will happen? That just because a novice was on duty, an important diagnosis can never ever be missed. So you will have rapid triage, accurate diagnosis, near accurate treatment, even at the hands of very, very junior people sitting there. So I feel we will not be off. Our roles will change for sure.
In the same
Last
connection,
question
there
by
is.
Dr. Mahadev sir.
Yeah. Data.
Patient consent is required or not when we use AI for this
Exactly. No, exactly. That's what my last slide said. There are some ethical concerns of using.
But are you using this thing?
Yeah. We see for our two trials we have taken the ethical committee is concerned, and we take consents. Absolutely, yes.
That is what. Very
Yeah.
good. Thank
AI
you.
field has now gone to the agentic AI.
Yes.
That's something about agentic AI.
Yes.
Coming googling up to us and they say, okay, so this is the possibility, this is the possibility. So can AI extrapolate that much that the patient themselves will take that help of AI and our role will become minuscule?
No, I don't think so. See, for example, today also people are taking use of Google, and they come with 5 Google questions every time on their iPads written and all. And there is a official syndrome now called idiot syndrome. Internet derived information obstructing treatment. No, it is official. It's not Ponde's made. It is official syndrome. Idiot syndrome is official. Internet derived information obstructing treatment. So, yeah, it's official. So, what I'm saying, today also they are coming with questions. That time also they will come with questions. Ki doctor, this particular algorithm has shown me that I am likely to develop diabetes in next 6 years. What is your take? There you will be. So, yes, and why could it be take? That patient has family history of diabetes, patient is obese, sedentary, etc. So it will give you opportunity to do primary prevention. Thank you.
I think, thank you, sir. And so looking to the specificity of and the role of AI in cardiology, in diabetes and in medicine, I think shortly NMC will start the AI in different field of study, and they will make the guidelines, and to all the new student has to learn AI compulsorily. So
Dr.
thank you very much, sir.
Please come on the dais, sir, for your felicitation. Dr. Mahadev Desai, sir. Please felicitate Dr. Ponde, sir. And would request Dr. Anand Shukla to come on the dais to felicitate all our chairpersons. And Dr. Utsav Patel to come on the dais. Dr. Anand Shukla to felicitate Dr. Urman Dhruv. Thank you, Ponde sir, for enlightening all of us. Dr. Utsav Patel to please hand over the mementos to our honorable experts. Thank you all the chairpersons and experts. For the next session, I would request to chair the session Dr. Darshan C. Shah, Dr. Ami Parikh, to please come on the dais. Dr. Darshan C. Shah, sir, Dr. Ami Parikh, Dr. Pragnesh Vora, Dr. Shalini Pandya. Please come on the stage and chair the session. Experts for the same meeting, Dr. Sneha Shah, Dr. Shaila Shah, Dr. Nehal Sadhu. Shalini ma'am, please come on the right side. Yeah. Dr. Praharsh Pathak. I would request Dr. Darshan Bhai to please invite the speaker.
Good evening, everybody. Sudden death is a very baffling and mysterious issue for all medical practitioners. Dr. Yash Lokhandwala is going to enlighten us today on issue of the sudden death, and particularly for the clinical scenarios and community approach for the same. Dr. Yash Lokhandwala is such a familiar figure in all national and international conferences that he hardly requires any introduction. But as a formality, I'll give his brief introduction. His educational qualification MD, DM and FSCC. His special interest is in heart rhythm disorders, and at present he is working at Holy Family Health Center, Bandra, Mumbai. I'll request Dr. Yash Lokhandwala to deliver his expert speech.
Thank you, sir, and thank you for inviting me and allowing me to select this topic, because Jai had given me another topic, and I thought that this is something close to my heart for the last several years. And also I'm happy to see Jagdish Hiremath here, because he has been a very integral part of this effort that we have been trying to take against all odds. So let's look first at the topic, and then we look at what we can do in the community, specifically in our Indian setup. So sudden death is a natural death, unexpected, in a patient who may or may not have known heart disease. Even if the person has a known heart disease, is not expected to die suddenly. So within 1 hour of acute onset of symptoms is as a collapse, then you call it as a sudden death. We know about sudden deaths, crib deaths, sudden infant death syndrome, but that's a very minor number of all the sudden deaths. The commonest age group for sudden death is the middle age, not the very elderly. So between 45 and 65 typically in the Indian context. If we look at cardiac deaths and how many of those are sudden, and then see at different ages, the younger a person is and has a cardiac death, the more likely is to be sudden. For example, in a person who's 25 years old or in that age group, 75% of cardiac deaths will be sudden. As you grow older, the percentage of sudden death in the older population is about 50%. In people who are more than 35 years of age, the incidence of sudden death is about 1 to 2 per 1,000 per year. Now, this can vary in different parts of the world. In India, we don't have full population records, but when we extrapolate from whatever restricted figures, data we have, and we extrapolate also from the fact that how much is heart disease more common in India, then we come to around 1.5 to 2 million sudden deaths in India. That means about 15 lakh to 20 lakh people die suddenly in India every year. In the younger population, less than 35, it is extremely uncommon. It's just 1 to 8 per lakh. In people less than 65 years of age, there's quite a male preponderance. 4:1 is male to female ratio, but in older people, the female incidence rises and the ratio almost tends to equalize the older you get. People are getting more and more athletic, running more and more, exercising more and more, and marathons. I think India has something like 3,000 marathons a year. So, yes, you run a marathon, but do it for your own kick. Generally, marathoners live less than people who exercise sensibly and moderately. So, the incidence of sudden death among athletes is almost 3 times compared to that of non-athletes. And in young athletes, the ratio of male to female is 10:1. If one of your parents has a sudden death, you have double the chance of having sudden death. If you look at the underlying causes that lead to sudden death, and if we go from age, so in children and young adults, there are more electrical problems, what we call channelopathies. So either catecholaminergic ventricular tachycardia or long QT syndrome. These are the commoner channelopathies. There are other uncommon ones. And then you have structural problems, the typical cardiomyopathies. hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy. We no longer use the term ARVC. We call it arrhythmogenic cardiomyopathy of the right ventricle, left ventricle or biventricular types. But even this is quite variable in different parts of the world. For example, in Western countries, in younger people, about 10 to 15% of all sudden deaths are cardiomyopathies, when Japan is 30 to 35%. Whereas the commonest underlying substrate in after middle age is coronary heart disease, which is around 75% in the Western hemisphere, but just around 50% in Japan. So there are regional variations. Having said that, the major chunk is acute and chronic coronary artery disease, followed by cardiomyopathies of various types, and the least common are channelopathies as underlying causes of sudden death. And what is the final event that leads to sudden death is most commonly a ventricular arrhythmia, and very less commonly primarily a bradycardia. What is important to recognize, and this is from a classical Holter published many years ago by Mark Josephson, is that this is a person who died when the Holter was applied and the data was retrieved, that within 10 minutes you go from sinus rhythm to relatively organized ventricular tachycardia to polymorphic VT to asystole. Now why it's important is that in hospital cardiac arrest or in ICU cardiac arrest, typically our witness cardiac arrests are ventricular arrhythmia, where prompt defibrillation, the ICU will at least immediately revive more than 90% of people. But most out of hospital cardiac deaths, if not picked up immediately or not acted upon immediately, will soon result in asystole. So the chance of reviving a ventricular fibrillation in the ICU is more than 90%. A chance of reviving someone who has gone into asystole is zero, nearly zero. So that is why one should recognize and act on cardiac arrest as fast as possible. And why is it important? You will say, but most cardiac arrests will occur in the ICU, isn't it? Wrong. Yes, those who are in the ICU, those who've had acute MI, those who've had heart failure and are admitted, they are high risk. They have almost 25-30% chance of sudden death in a year. But if we look at who of all sudden deaths, for example, we say in India 15 lakh people die suddenly every year. A majority, 90% of them, that means about 13 or 14 lakhs will be in the general population. They will not be patients who are identified at high risk or patients who are in the ICU. In fact, 80% of cardiac arrests are out of hospital cardiac arrests. So majority of cardiac arrests are out of hospital in people who are not identifiable at high risk, because this denominator is so huge. That most deaths will occur there. And hence, early recognition and early action is what the community approach should be. It's not doctors, it's not paramedics. It's the lay people who need to be involved to make a difference in cardiac arrest in a meaningful manner. This Swedish study, and Sweden, Scandinavian countries have one of the best records in resuscitating cardiac arrest. As a nation, of course, as isolated pockets, you have Seattle, which has one of the highest revival in sudden death, or you have Tokyo. But as a nations, it is the Scandinavian nations. If you look here, the time from cardiac arrest to the first defibrillation, if the time is less than 2 minutes, you have a 50% survival. But when the time is 10 minutes or more, it goes down to 10%. To roughly every minute wasted without at least CPR, every minute wasted reduces the chance of survival by 10%. And this is a typical scenario, used to be the typical scenario in India. This was a slide I've shown several times sent by Rabin Chakrabarti from Kolkata, but it's true for most parts of India. But the scene is changing. So this man is dead suddenly, people are watching. The thing is, now we say recognize cardiac arrest and act on it. And the chain of survival in cardiac arrest has changed. When I was a medical student, for cardiac arrest, it used to be the hospital which was thought to be most important. But now it's the person on the spot, the bystander, who's the most important. So we say call, push and shock. If you recognize cardiac arrest, call for help. Push means start cardiac massage. And shock means look for the closest defibrillator. You are the hospital or paramedic or ambulance has to come to you rather than you taking a cardiac arrest victim to hospital. And if we look at Seattle, which has one of the best survival rates, in fact, citizens of Seattle take it upon as a pride to take out as an insult if somebody dies of cardiac arrest without attempts to revive. What did they find? That if you start CPR within 4 minutes and get access to defibrillator within a few minutes, almost 50% survival. But if you do not start cardiac massage, the word massage again is a little distinct because you see in Hindi movies also people actually just massaging the chest. So it should rather be called compression, chest compression. If you don't start chest compression within 10 minutes, then whatever you do after that, the chance of survival is zero. I said Scandinavia has one of the best outcomes. If you look at this, it's amazing. If you look at this study from Stockholm, when you have public access AEDs, so AEDs have to be at railway stations, malls, crowded places, big housing societies, public access AEDs, police stations, then they had 70% survival, 70% survival. And a systematic review of many different studies showed that in places where they had public access defibrillators, overall there is 40% survival of cardiac arrest, which is a big number, Because in India, I don't have figures, but I can confidently say that it is less than 0.5%. And therefore, what we should be doing as a community, and we started this effort several years ago in a small way, and this movement is growing. It's the cardiologists, physicians, anesthesiologists, even doctors from all other specialties in different parts of the country who are coming together to make people move, at least have a simple training, which is less than 1 hour. Simple training is enough for people to administer chest compressions. And those who are interested, especially college students, go for little more training and become trainers themselves. That's the way we must move the lay bystanders or lay people from being aware to being trainers, especially the younger generation. So, with this in mind, in 2017, we started iCare, Cardiac Arrest Resuscitation for Everyone, which is now called the Revive Heart Foundation. The Anesthesia Association, others in other parts of the country also have been doing this work. But unless we all join hands, I don't think it will come to anything meaningful. Several of my colleagues said, it's a good thing that you're doing it. We will cheer you if anything comes out of it. And actually, we witnessed 3 sudden deaths amongst doctors, all in their 40s within 3 months. And that's when we thought, let's do something at least. Okay, we may fail, but at least let's do something. We realized that whatever we do, we can reach audiences like this, we can teach in schools and colleges, but people have to be motivated. When we used to have programs in health clubs, only the 60 plus would attend. Youngsters would not. And we realized that to increase the reach, we need people, we need to use social media, use celebrities, use sports person. Luckily, many of them were forthcoming, cricketers, tennis players, badminton players, Olympians, and our colleagues, doctor colleagues who were there, doctors in one way or the other helped us get. And so when, for example, this same video, when we made it, we could reach out to maximum 20-30,000 people. One video made by one of the film stars for us reached in one day 2 million people. And so far this video has been seen by more than 5 million people. So I think, so important thing is that there was no formal training for cardiac arrest for us as medical students. Now there is. We were taught to check the pulse. It's wrong. Now it's conclusively proved it's wrong to check the pulse to diagnose cardiac arrest, because if someone really has a cardiac arrest, you might be stealing your own pulse. And if someone doesn't have a cardiac arrest and it's a feeble vagal episode, you may not check the pulse. So you have to look at whether the patient is conscious or not and whether the person is breathing or not. Because except cardiac arrest, there is no other condition which causes these two. All other causes of unconsciousness, whether it is a hypoglycemia where we recover, or a stroke, or an epileptic attack, after the first 15 seconds you will start breathing. Not the gasping breathing, but you will start breathing. So that's what we call recognize. That means look, tap. No response. Look and tap. Look for breathing. No breathing. You diagnose cardiac arrest. So it's easy to teach the lay public to recognize cardiac arrest. The fears when we started, the fear was, the skepticism was, who in India wants to get involved? If there's a road accident, at the most somebody will call the police but drive away. Nobody wants to get caught into that mess. Now we have the Good Samaritan Act in India also. So if you were to try to revive somebody for cardiac arrest, you cannot be penalized because anyway that person would be dead. In fact, that was the major reason to get the police trained. So the police is your friend rather than the police coming in your way if you try to help someone. So we started in 2017 and so far we have trained about 3.5 lakh people in CPR with more than 1,000 training workshops and installed several public access AEDs. So this is an example of the public access AEDs installed in the suburbs of Mumbai. And also one of our colleagues, Dr. Akshay Mehta, along with the road stations of Mumbai. You see the I was today also disappointed when I saw AEDs at the Mumbai and the Ahmedabad airport which said to be used by trained personnel only. That defeats the purpose. And I called up the superintendent, hopefully they'll remove it. And AED is supposed to be idiot proof. It's supposed to be used by anybody. That if you say trained personnel, then most of the time there won't be a trained person to use the AED. In fact, Dr. Jagdish Hiremat and his group in Pune have installed, I think, Jagdish, more than 20 or 25 public access AEDs. These are some examples. So the first person who survived as a result of our small effort, who was revived by somebody trained by us for CPR, who not only used chest compression, but also got an AED from a close by, it was close to Otters Club at the Bandra Carter Road. In fact, when we retrieved later on the AED information, we found that actually the patient had gone into polymorphic VT, VF. This is the first shock where he came back to normal rhythm, but soon had bradycardia, again developed VF. He gave a second shock and the patient survived. In fact, the person who revived him, Samir Farishta, was himself getting panicky. He said after 2 shocks if he doesn't revive. And there's a policeman standing there who said, why are you doing this? Let's take him to Holy Family Hospital. So he was saying if he doesn't survive, I might be in trouble. But this patient is alive and well now. This was another person while playing tennis. He had a cardiac arrest. He was revived. There was another doctor colleague, an ENT surgeon who was also playing tennis who revived him. And they used an AED which was in the gymkhana. In fact, all health clubs, all gymkhanas, again, they are high risk areas for cardiac arrest. Dr. Ajit Desai, one of our colleagues, has himself saved 2 people out of hospital with cardiac arrest. So this person was playing badminton with him in the MIG club when he collapsed. The MIG club didn't have an AED. So he started massage, got an AED from his own building and revived him. And this person in his own building, in the morning walk, had a cardiac arrest, who was revived. But these were all, the best, one of the best stories, apart from the first one of Samir Farishta. I'll share with you 2 very wonderful stories. Marine Lines railway station, AED was installed a couple of months ago and the railway staff were trained in chest compressions. And within 2 weeks of doing this by Dr. Akshay Mehta and his Rotary group, 2 railway staffers, including this gentleman, found somebody collapsed, recognized cardiac arrest, started cardiac compressions. Someone ran and got the defibrillator from the station master's cabin. They shocked him. Twice they shocked him. They revived him. Then he was taken to the close by hospital, found to have a ACS and survived. So can you imagine a railway staffer without a doctor, without a paramedic saving somebody? It was unheard of. It was unheard of in Mumbai. Thousands of people must have died in trains and in the railway platforms, And in fact, one of my patients who had a cardiac arrest when he was in USA, there somebody revived him. He said, "Mi Thaneyat asto." If I was in Thana, people would have said, "Darudia padlay rastevar." People, drunkard is lying on the road. But so things can change. This was an Indian girl in UAE was revived. This is a policeman. So there's a policeman who saved somebody in Lucknow by prompt chest compression. Ahmedabad, policeman has saved someone. So we are seeing more and more success stories of people who have been saved out of hospital. And I think we need to teach at least 20% of the population about cardiac arrest, because if there's 20% of the adult population knows about it, then there's a good chance in India that somebody around 1% at least will know about it and will take the lead, and we have to reach that threshold. This video, Dr. Vinod Singla is one of our colleagues in Hissar who had trained his society, his big colony in his area in cardiac arrest. Sorry. And this is another story from a lady who was living in his society, and it's a short clip which I'd like to share with you. Yeah.
मैं संगीता ग्रीन पार्क से मैं कुछ दिन पहले वॉक कर रही थी। वॉक करते हुए मैं गिर गई थी, तो मेरे कुछ फ्रेंड्स मेरे साथ थी जो वॉक कर रही थी। उन्होंने मेरी छाती दबाई, सीपीआर किया, और उसके बाद डॉक्टर विनोद सिंगला जो हमारे ग्रीन पार्क में ही रहते हैं, तो उन्होंने भी हमारा सीपीआर किया, मेरी छाती दबाई, और नेक्स्ट डे मुझे हॉस्पिटल लेके गए। और नेक्स्ट डे उस टाइम मुझे हॉस्पिटल लेके गए, और नेक्स्ट डे मुझे होश आया। तो ये 2 महीने पहले हमारे ग्रीन पार्क में कैंप भी लगा हुआ था, जो डॉक्टर विनोद सिंगला ने ही लगाया था। उन्होंने सीपीआर सबको सिखाया था, उसी की वजह से मैं बच पाई। तो मैं यही चाहती हूँ कि सभी लोग सीपीआर सीखें, उसका फायदा उठाएं, ताकि आप लोगों को भी भगवान ना करे किसी को कोई ऐसी दिक्कत आती है तो अपना सेफ्टी अपने आप से कुछ तो हम कर पाए। धन्यवाद। मैं
So then we thought, every year let's have a cardiac arrest awareness week, and this started in 2021 as COVID, when we were still in the COVID era, and several cities participated in this cardiac arrest awareness week. So we repeated it in 22, a second cardiac arrest awareness week in September, October, where we had 2.5 million online views. The awareness week 3 in 23, where Ajay Devgan helped us a lot in popularizing it. Many more cities participated. And recently, a couple of months ago, we had the awareness week 4, where the actress Kajol helped us in, and a lot of our doctor colleagues in different parts of the country took this movement forward. Now we have created an app with the help of some funding, but this app is free. This app will not only tell you about cardiac arrest, tell you about how to give chest compression, but also in some cities, and this app will keep getting upgraded continuously, tell you where are your close by AEDs. And hopefully in future it will also alert the volunteer trainers in your area. This is free. There will be free upgrades. So please encourage people to download it, both on Android as well as on Apple. It is downloadable. And this is the contact details which you can share for anyone who wants to learn CPR either online or in person, at least in Mumbai and in other cities. We can direct them for the same. So I'll end here by saying that the government At some stage, this has to be a program taken by the government. At some stage. But we can't wait for that stage. And I think they have a lot of other health priorities. But if we at least show, and now the next step will be to find out how many lives have been saved, how much cost effective, how much it is. But if this effort grows, then I'm sure we are moving in the right direction. Thank you.
Thank you, sir. Thank you.
Dr. Yes, just want to tell you that we are invited tomorrow to meet Mr. Nadda, the Health Minister of India. He is in Ahmedabad tomorrow. And Ahmedabad Physician Association was invited with dialogue with him. There is many associations invited to have some transparative ideas and views, and they want to take the healthcare to next level. So they invited all of our associations office bearer to give some idea. We will definitely take this point personally to.
I think what you should impress on him is to make it compulsory in schools and colleges. Before somebody passes out from class 10, class 12 and graduation, there should be a couple of lectures on cardiac arrest, and there should be at least a 5-mark question, because what works in India is if there is a question, they will study it.
If possible, we will.
It doesn't cost the government anything to implement this in the syllabus.
Yes. And if time permits and if we get time, we will take time to meet him somewhere else or in detail also. Thank you.
Thank you.
So what question from here?
Incidence of sudden death increasing in younger generation. What is your take on it?
I think there is no doubt. There is no doubt. I think all the cardiologists here also would probably agree with me that vascular events, whether they are cardiac, venous vascular events, you talk to the radiologists, or cerebrovascular events, have definitely increased in the post-COVID era, especially amongst the younger generation. I don't have hard data from India. There must be. I'm not aware of it, but this is the observation of mine at least, and many of my colleagues.
Can you just
I think there's more thrombogenicity, I think.
So is it that we are reporting more cases, or we are seeing more cases, or is it post-COVID, or it is because more marathons are being, you hear lot more
I'm
about
not talking
that.
of sudden death. I'm talking of vascular events.
Okay, yeah, sudden death, it could be any of these three, or do you think, because
Suddenly
we are seeing lots more.
marathoners, sudden death is a very, very minority. Majority would
Almost every other marathon has one person.
be. India has the
Is it because
highest
fluid electrolyte imbalance leading to BT or something?
numerator-denominator ratio of the number of people running marathons versus numerator being the sudden death. India is highest.
So my question is related to
I
that.
think in marathon, there should be all along the marathon route, there should be at particular points volunteers available who can know how to resuscitate and defibrillators available.
So my question is related to that. You showed that 2.8 times more deaths in athletes than non-athletes. And so the incidences that we hear are mostly for non-professional athletes who are doing either hobby sport or running marathons and cyclothons and all that. Not the ones who are playing professional sport. And sir, as doctors, we are the community who has, encouraged this exercise fad going into the public. So what possibly do you think is the reason for this?
Exercise is good. It's a bell-shaped curve. No exercise has the highest morbidity and mortality. Moderate exercise, you're better and better and better till you reach a peak. More than moderate exercise, you plateau and then start going. Severe exercise, start going down the bell-shaped curve. So moderate exercise is definitely good. Moderate exercise means even 5 days a week, if you walk for 1 hour, is good enough. The problem is, and I had given this all the risk factors in one sentence when I had spoken in one of the American Heart Association meetings. A middle-aged obese man, a smoking middle-aged obese man, hypertensive, goes for an unaccustomed vigorous jog on a cold winter Monday morning. So remember, these are all risk factors. So unaccustomed exercise, especially in a cold environment, especially suddenly, you're not doing anything. Now suddenly you decide to play a badminton tournament because you had played 5 years ago, you're at risk. So whatever exercise you do it sensibly.
Because, sir, in your examples also, somebody was playing tennis, somebody was out for a walk, somebody was, I mean, doing some form of exercise when they
Not
dropped
necessarily.
unconscious.
I mean, couple of those.
Two or
yes.
three examples were like that.
Yes. So unaccustomed exercise and vigorous exercise is bad, but sensible exercise is definitely good. No, I will tell you, if you take details of this gym, this gym trainer is a big fad in Bombay. I don't know how it is in Ahmedabad. And majority of the trainers, even of the celebrities, are Anguta Chap. I always asked, has your trainer ever heard of Krebs cycle? I'm sure they have not. They pump artificial proteins. They give all whey proteins, bottle proteins. There was one gym trainer who was even given amphetamine. Means what one is doing, the other will do. They make people go out of, they push you for what? You know, they make you, those barbells and all, when they were doing, people have collapsed. So sensible amongst those who collapse in the gym, majority of them have not been doing sensible exercise and have been taking all these funny things. And the worst part is, they are not CPR enabled also. In one gym, in our whole health club, I'm sorry to say, they were making him smell the chappals. Then the person collapsed.
And so that incremental weight training and all that is also there. I think there's
This
a capacity for
high
a person
intensity
to have a certain
training,
weight.
intermittent fasting, or see all this it's a big, very popular among youngsters. It has some benefits, but the risks and the disadvantages outweigh the benefits. You can't keep up that type of lifestyle. So it's better to adopt something which is moderate and which you can maintain for several years.
Thank you, sir.
Would there be any difference?
Wants to go for some high intensity training or gym, do you recommend regular cardiac workup, particularly to rule out HOCM and long QTC?
See, those who are taking competitive athletics or competitive sport, they are now in many countries mandated to rule out underlying heart disease by a simple ECG and echo if you're really being competitive. So that makes sense. But for everybody who's going to gym, that is not really required. More important is be sensible.
Is it commoner in isotonic exercises than aerobic, or you haven't noticed that difference?
No, it is more in the isometric exercises, especially the heavy weight training.
They keep on increasing the weight in 2 years. They reduce the weight in 2 years. How do you explain that? And what is the effect on the body?
No, there's, I don't know how popular it is, but now this semaglutide and this new one, this Ozempic, we have the tablets, and now the Monjaro,
Right.
they have become extremely popular in amongst the younger generation, especially among these celebrities, and sometimes they are forced to do it for their profession. Obviously, it's not good. I mean, these going up and coming out. It works. It works. It works in reducing weight. Dramatically works, but I don't know.
That has just recently come. In
Which
the
one?
Market, like, but this has been happening for years together.
Yeah, that's true. That's true. As on the lighter side, one of the talks on this inclisiran. So in Sion Hospital, the medical rep had come. So the cardiac surgeon told him, you are the wrong place. I mean, if you give inclisiran to my Sion Hospital patient, definitely his cholesterol come down because he won't have money to eat only after that.
So, few months ago, there was some camp in the Bangalore hospital. Okay, they have screened around 200, 2000 ECG in a day. It's a primary prevention. Do you suggest screening of ECG in all the population?
No,
This is
no,
marketing.
no. See, ECG is simple and inexpensive tool. As Ponde said, with artificial intelligence, definitely. See, you're using the simple ECG of 100 years ago because it's so easily done and you have such a vast database. So it can tell you, especially those who are running a marathon and all, definitely that ECG screened by AI is a good idea. You can't do echoes for everybody, but it'll tell you who is at risk.
But that was for general population. They want to screen all the population for ECG to assess
The-
congenital syndrome or QT syndrome or
To
something.
prevent sudden death, it's not going to, I doubt whether, because just one single ECG to prevent sudden death may not be it won't really make much of an impact.
not for the
In a routine clinical checkup, do we need to tell this patient that
See, I never look at that computer interpretation of the QT. So I always look at the QT myself first. And then if it looks, then that's quite accurate. So sometimes, again, as Ponde said, it depends on good data. See, there's a typical this thing in computing, garbage in, garbage out. In India, half the ECG machines only are rubbish. Half the stress test machines only are rubbish, especially where you see that linked median. So what artificial intelligence will do with that such data? But QT interval, so therefore at faster heart rates, it's often will show you long QT because it doesn't adapt so fast. If the QT is more than half of the RR interval, look at it more closely. That will be the rule of thumb.
Cause of sudden death, right? Cardiac death is sudden death.
See, sudden death is more or less synonymous with sudden cardiac death. There are very other few causes where you will collapse suddenly and die. Yes, there are. For example, suddenly a massive brain aneurysm rupture, a sudden aortic rupture, sudden massive GI bleed. But they will account for together less than 10% of all sudden deaths. So 90% of sudden deaths are sudden cardiac deaths.
I think we will
Thank
end
you
the
so much,
session
sir.
here.
Would request
Thank
Dr.
you, sir.
Ami Parikh ma'am to felicitate Dr. Yash, sir. Would request Dr. Jay Shah to come on the dais and felicitate our chairpersons. Dr. Jay Shah, please come on the dais. Would request Dr. Devang Patel to come on the dais, please. Dr. Devang Patel, please felicitate our experts. Dr. Shaila Shah, Dr. Sneha Shah, Dr. Nehal Sadhu, Dr. Praharsh Pathak. I would request everyone to join us in the evening with the famous RJ Dhwanit. He would be giving some really interesting talks. He's a famous radio personality. Around 8 p.m. he would be here. Would request all the delegates and faculties to enjoy a lovely evening with him. For the next session, I would request to chair Dr. Jay Shah, Dr. Harshad Patel, Dr. Dilip Unarkat sir, Dr. H.D. Nagarani to chair the session. And for the same session as experts, Dr. Janak Kamboja, Dr. Neerav Shah, Dr. Dushyant Balat, and Dr. Vishal Sambara. Would request Dr. Harshad to invite the speaker, please. Dr. Janak Kamboja.
Samir,
Please
I
come on the
don't think Samir Bhai needs any formal introduction. He is an eminent cardiologist of Gujarat and I would say India. Over to Dr. Samir Dani. Please be instructed.
Thank you, sir.
So good evening, and needless to say, I'm privileged and honored to be here. And thank you, Arshad. Most of the time it happens that people say that it doesn't need introduction and then embark on a good 10 lines of introduction. So I was little worried. More worried because of Yash's inclisiran example, because I'm going to talk on inclisiran a little bit. Okay. So, lipid management is oft visited. In last 30 years, I think number of talks each of us has given or listened to on lipid management probably would be in more than hundreds or probably literally amounting to 1,000. Still, we keep on visiting lipids. One of the reasons is, it reminds me of a very often told joke, very old joke about a certain person who was in the dark of the evening was searching something very frantically just below the street lamp, and somebody came and joined him and started looking for it, whatever was lost. And he asked him, what is it? And he said, it's the ring. Third person joined, fourth person joined, and after a while nothing was found, and they asked him, sir, where exactly you dropped it? And then he showed some 20 feet away a dark spot, and they said, why you are not looking there? He said, no, because light is here. So many times we thought that we are treating LDL because we can treat LDL and we can treat hardly anything else. And that is the reason why we treat LDL. That's the reason why we treat cholesterol, because that's most easily treatable. We can reduce cholesterol, LDL from 160 to 40, 30 nowadays. And that gives us a kick. What we can do, we cannot do that with blood pressure. We cannot do that with diabetes. The patient will die, in fact. And here, patient doesn't die. And we seem to discover that not only the patient doesn't die, maybe he's getting better. And that's why so much of interest in lipids. Another example that I remember is an article by W.C. Roberts, written in 2001, and I attended his talk also, was fortunate to attend that talk. And he argued very persuasively, in 2001, mind you, that cholesterol is the single most important predictor of atherosclerosis. And he argued that there is no hypertension, no LVH, and still person can get atherosclerosis and an event. There is no diabetes, sugar levels are absolutely normal, still a person can get heart attack, and it will be difficult to treat by lowering sugar or by lowering his blood pressure. But no matter what the cause is of heart attack, you bring LDL down, you bring cholesterol down, and that person benefits. That is true. Even a smoker or a tobacco chewer doesn't benefit as much by stopping the smoking as the benefit is seen by treating the cholesterol. And that's probably the reason why we talk about the cholesterol. Cardiovascular disease is leading cause of death worldwide. Still true. This kind of something like this I have shown for nearly 25 years, more than that, in every talk about cardiovascular prevention or disease or cholesterol or whatever, no matter what cardiac talk you give. This is there since last 30 years, barring accidents and barring infections in some poor countries. India used to be one of them. Cardiovascular disease is the #1 cause of death everywhere. There is only one state in US which has overtaken, where cancer has overtaken CV death as #1 cause of death, all types of cancers combined, mind you. But other than that, not a single country where this is not a leading cause of death. The disease burden in India, again, these kind of slides used to give the shock and awe type of effect. It doesn't anymore. Indians have higher ASCVD risk. They develop it at earlier age. they exhibit more severe form, they have higher mortality, they have poorer outcomes when treated. All this we know very well. This study, yes, it did to some extent shock and awe us. ICMR INDAB study, which came out in 23 in Lancet, one of the most meticulously done study to come out from India. And it showed that the prevalence of CV risk factors was so high, very unlike what we used to think. And even for people who are in the field, for them, this was really eye-opening. I'll talk a little about Lp(a), non-HDL and LDL-C clubbed together as risk factors. These are all atherogenic lipoproteins, and these all molecules or these all particles carry ApoB molecule. So all ApoB containing lipoproteins are associated with increased risk of atherosclerosis. This is something what we have understood. Lot of evidence on this. I'll not be able to show you all the references because there are so many. The overall atherogenicity of cholesterol is probably due to apolipoprotein B. All the particles which carry this molecule have atherogenicity of various degree. In general, we have talked a lot about LDL cholesterol versus non-HDL cholesterol versus small dense LDL versus ApoB. Which one is more accurate predictor of CV outcomes? Which one is more accurate predictor of atherosclerosis? In general, all correlate very well with each other, no matter what you really measure. And LDL-C is now most accurately and consistently, almost everywhere, every lab now measures LDL-C very well. So that incongruity is much less nowadays. So LDL-C still holds sway. Non-HDL-C could be probably more accurate in predicting the risk, but more or less LDL is the measurement which you find very easily and very relatively inexpensive. How atherosclerosis develops, this or some kind of this busy slide, everyone has seen how LDL-C particle goes into the vessel wall, how it goes into the cell membrane, how macrophages approach it, how the foam cells are formed, how a fatty streak is formed, and then how oxidization takes place and how later on calcification takes place as the plaque stabilizes, and how plaque ruptures and how it gives rise to events. All these things are very well known, and I don't think we need evidence. We need to spell out the evidence for that. So if you look at LDL cholesterol or non-HDL cholesterol, we know that all lipid lowering therapies basically act by lowering the LDL, by increasing the hepatic uptake of LDL-C, and thereby increasing the clearance of LDL, and they achieve the target. No therapy not affecting LDL, affecting only triglycerides or affecting HDL only, has been shown to improve cardiovascular outcome. So lipids are very important. LDL is the central driver of atherosclerosis and probably to some extent events also. Of course, there are many precipitating factors like undue unaccustomed physical exercise, or a very single large fatty meal, or partying, holiday heart syndrome, and lots of other things. These are all precipitating factors for plaque rupture. But the plaque formation, progression, and even to some extent the plaque rupture is driven by LDL-C. A little bit about Lp(a). A long back, Inas A. Inas wrote about high prevalence of increased LP-little-a concentrations in expat Indians, South Asians, in fact, Southeast Asians. And then we have learnt a lot very slowly over a period of 30 years about LP-little-a. We believe that LP-little-a is genetically determined. We believe that LP-little-a is very important risk factor for atherosclerosis and events. We know that LP-little-a is very important risk factor for development of aortic stenosis. We know that in presence of LP-little-a, effect of all other risk factors gets magnified. So if a diabetic has high LP-LA, the effect of diabetes on his CV risk increases. Same thing goes for a smoker, same thing goes for hypertensive, same thing goes for any other risk factors that have been studied. All major risk factors are potentiated in presence of high LP-little-a. What we don't know about LP-little-a is that treating LP-little-a, bringing it down, does it improve the CV outcome? We do not know. There have been drugs which have incidentally lowered LP-little-a while lowering the LDL, and they have shown benefit, but that doesn't prove that that benefit comes from lowering LP-little-a. So in presence of high LP-little-a, the only recommendation we have now, right now, is that treat all other risk factors more aggressively. We also know, because of this, that LP-little-a determination or measurement is important only once in lifetime. Right now. That's what we believe. Because measuring it again and again, showing its fluctuations, it has decreased and it has increased, that increases the anxiety, nothing else. Doesn't have any other indication or benefit. If you talk about relative heterogeneity of LP-little-a and LDL, LP-little-a particles are very small. Overall, very less concentration, but if you take particle to particle, heterogeneity is supposedly 5 times that of LDL particle. Again, not a very clinically relevant information. All said and done, amongst the topmost risk factors for atherosclerosis and for cardiovascular events or MACE is LDL-C. Another thing which we have learned over these 30 years is that the LDL cholesterol, LDL-C magnitude and duration of exposure determines the risk. If you check somebody whose LDL-C is at 140, another guy whose LDL-C is at 160, you automatically assign more risk to the 160 LDL fellow, saying that all the other risk factors are same. But that is not always the case. Many times you see that the person with 140 or 120 LDL got the heart attack first. If LDL-C is the central driver, why does this happen? Because you do not know what was the LDL-C exposure of that particular person over so many years of life. That has never been measured for cholesterol levels. So LDL-C exposure to the vascular tree determines not only the magnitude. When you check the magnitude, it's a snapshot. It is, as I always say, that I would always like to say, like one of my teachers used to say, that all these snapshot tests are like taking a picture, like a snapshot. Someone is smiling, that doesn't mean that he is always smiling. And someone is crying, that doesn't mean he is always crying. You are trying to determine that this person is smiling, so he will be smiling 10 years later. Not going to happen. So LDL cholesterol magnitude and duration of exposure, this is seen in now many, this has been confirmed by many meta-analysis, and cumulative LDL-C exposure, and we'll come to that, some interesting facts later on. And that has changed our LDL-C goals in last 15 years. Last 15 years, we were talking about LDL-C less than 100, then we were talking about LDL-C less than 90 in Indians, 10 less than Western counterparts. Then we talked about LDL-C less than 70 to treat the atherosclerosis, to get the secondary prevention. And now we are talking about 40. Another thing that has come up recently is early lowering. Once you get ACS, LDL should be lowered as early as possible. Why? Because the first 90 days after ACS is a critical period, and this is where there is acute increase in the recurrence. So 1 in 10 patients reported a second MI or a stroke or a CV death within the first 3 months of experiencing an MI. So death, MI, or any recurrence of MACE is elevated in first 3 months after the ACS, and that's why it is very important to reduce LDL as early as possible. Does it benefit? Yes, there is evidence that it does benefit if you lower the LDL very fast, start from the first day, and if you reach your LDL goal within first month, it gives you more benefit. And if you reach your LDL goal in first 7 days, it gives you even more benefits. And there are a number of trials suggesting that. And how early is early? As early as possible. Another question is how long we keep the LDL lowered. Today I had a patient who said that I have done 3 injections of evolocumab course. Then I checked my LDL, it was 58. So my doctor said, do 3 more, 1 more course. I had hard time explaining to him that it is not a course. This LDL you are going to require for lifetime. And sustained lowering is important. That has been shown by so many trials. Long-term lowering of LDL-C lowers the risk of events long-term basis. So all these studies, if you make a meta-analysis, that long-term exposure to lower LDL-C level is associated with lower risk of MACE compared to short-term exposure to lower LDL-C. So longer you keep the LDL-C at target or at goal, better it is for the patients. If you look at the Sweetheart study, interesting scenarios. One group where you don't reach the target LDL at any given point, studied for 1 year. Second, you reach the target at 2 months, but are not able to sustain it for 1 year. Scenario 3, you don't reach the target at 2 months, but you reach at the end of 1 year. And scenario 4, you reach the target at 2 months and then sustain it for a period of 1 year. And I don't think that you need to look at the results of the registry, which scenario is best. So I'll just skip it. You get additional benefits of lowering it early and sustaining it longer over a period of 1 year. What if you sustain this target for 12 years? So you have meta-analysis for that also. If you sustain this target for 12 years, lower and longer is better. And you can see that from this particular table, which was there in this article of European Heart Journal. So lower, sooner and longer, that is where we are looking at about as far as LDL level is concerned. There are challenges to achieve this kind of reduction, because every time we talk about this, somebody will get up and say that it's not possible. My patients do not get to LDL 40 without side effects. And we have to reduce the dose of statin, or we have to do this and we have to do that. cost is also an issue, of course. And medication burden, patient compliance is a major challenge. And apart from compliance or apart from adherence to the therapy, there is LDL-C variability, which we have seen recently, that somebody gets to LDL 30, 20 very fast, and then as you try to sustain that level with the same therapy, the LDL levels creep up back to 50, 60, 70, 80 sometimes. Then you do something else and then again they go down. This kind of variability has again adverse impact on the MACE. So lowering the heart disease risk with reduced lipid variability, another goal which we are not finding it easy to achieve. So poor statin adherence, I will not go into the causes of this, why that happens. Even with PCSK9 inhibitors, the LDL-C variability is well established. Inclisiran has the potential to improve this compliance, and that is probably the most important aspect of inclisiran, because it's once you start, first dose 0, second dose 3 months, and then every 6 months, only 2 doses a year, improves the patient compliance or improves the patient adherence like anything. And this, from very small experience, we have seen that. And it demonstrates significant sustained LDL lowering. If you compare it with evolocumab, maybe little less LDL lowering, but in terms of compliance, it wins. That brings me back to this concept of sustained and long LDL lowering. This has come from a meta-analysis from William Horton et al., which was published 2 years back. And the concept is that how many years of life, every year, what kind of cholesterol exposure has been there. So you take an average of cholesterol exposure. So your cholesterol exposure, if you measure it 4 times or 6 times in a year, and it is averaging around 130, then your cholesterol exposure for that year is 130. If you count like that from year 0, what happens when a child is born or when neonate, LDL levels are around 40, 50. And then it goes up in teenage, usually it goes up to 120, 130, which we normally see. And then it creeps up by the age 30 or 40. And typically, you get first heart attack at 70. This is normal. At somebody getting a heart attack at 70, we say, okay, that's fine. That's how life goes, and 70 is okay. So that's normal. Based on meta-analysis of so many studies, they proposed that it's a simplified formula, but total 7 grams of exposure to LDL-C brings an event. Lifetime exposure to 7,000 milligrams of cholesterol brings an event. So if your LDL exposure is average 100 milligram per year, starting you were at 50, then 60, then 100, 130, average is out at 100, then you will get your first heart attack at 70. And that's normal, and that's how most of the populations go or used to go. If LDL level is averaging 200 milligram per year, the same first heart attack will come at age 35. And what is the proof? FH. Familial hypercholesterolemia patients who have from birth LDL levels in vicinity of 200. And typically, they get MACE or first heart attacks in their 30s. So the argument from this meta-analysis, of course it's simplified, but the argument Braunwald made in that particular talk was that if you average somehow LDL 70, I would get my first heart attack at 100. So title of his talk was how to get your first heart attack at 100. Very interesting. I agree that it is slightly simplified, but at the same time, there are lots of pointers and indicators that this is true. If you bring down the LDL level at 40 in your patient who is 60-year-old and has had significant triple vessel disease, meaning thereby he's already exposed to 7 grams of LDL-C. At 40 milligram average per year, it is going to take almost 25 years for him to get 1 gram more exposure. So if you detect them early and bring the LDL level down to 40, probably you will save a heart attack for next 10, 15 or 20 years in these patients. And this is the diagram from Horton et al. That red line is FH patients. By age 35, they get clinically apparent ASCVD. That orange dotted line is at 7 grams. If you catch them at 35 or 30 and you see that they have been exposed, for primary prevention, anyone who has been already exposed to roughly 3 grams, and you give inclisiran or some such agents, forget inclisiran from this graph, but any such agent, and skew that graph down, bring down his LDL level to maybe 50, 60 or 70 or 50, and then so that it averages out at 70 per year, then first heart attack at 100. Very interesting and thought-provoking calculation. Anyway, I'll end my talk here. Cumulative exposure to LDL-C increases the risk of ASCVD. That's key takeaway number 1. 1 in 10 patients report a second event within the first 100 days after experiencing an MI or ACS. Early and sustained non-HDL-C or LDL-C lowering results into the lowest risk of CV outcomes. Adherence and LDL-C variabilities are major challenges to achieve sustained reduction, and not only inclisiran, anything. In fact, efforts are underway now to develop a vaccine, and inclisiran is like a vaccine. If you can, forget everything else, if you can develop a medicine with no side effects, which can be given once a year or maybe once in 5 years, which is not very costly, Sion Hospital patients can afford, would it really reduce the MACE by 70 or 80%? In that case, it would be competing with lifestyle. Thank you.
Thank you so much, sir. Comments from the experts or chairpersons?
Sir, where will you put inflammation as one of the major
I'm sorry?
risk? Inflammation is one of the major risk contributor apart from LDL.
Absolutely. It's a very intriguing question. Number 1, inflammation is a very important precipitating factor. As far as inflammation is concerned, right now all the data points to it being a major precipitating factor. People who live close to highways, people who are more exposed to traffic pollution or air pollution, people who are exposed to water pollution, they all sustain higher amounts of events, higher number of events compared to those people who have the same risk factors otherwise and are not exposed to those inflammatory factors. Now, what about inflammation causing vascular narrowing or atherosclerosis? I probably would say that people like W.C. Roberts or any big pathologists would term it not as atherosclerosis, but for the better want of term, you will have to say something like that. But inflammation causes vessel narrowing, that is a fact. So probably the only other factor which works by some other mechanism other than driving LDL into the vessel wall, driving vascular narrowing in some ways other than LDL oxidation, is inflammation.
Lipid abnormalities.
Right now, all the associations recommend cholesterol screening at age 20. First screening at 20. If you have evidence to believe, or if you have more risk factors in a given individual, you can check it early. But by and large, for general population, first screening at age 20, and then 30 onwards, you start screening regularly.
Regularly means in a year, how many times?
Every year.
Yearly.
Yearly.
And when to treat without risk factors? At which age?
If you don't have any risk factor and LDL levels of 160 at age anything above 20, I would be inclined to treat that. But I would search for other risk factors first, and I would still give lifestyle changes a first preference. And by treating, I mean lifestyle changes is a treatment.
Because the model you have projected is something which is...
Yeah, if that is true, then it's like iodizing the salt. It doesn't prevent, it doesn't take away the thyroid disease, but it helps.
Samir, I had read somewhere long time ago that, human beings, if free of disease, and this is from Caucasian mountain, apoptosis, which will eventually kill you, of natural is 180 years is human life. Now, for that 180 years, is there any science that what should be the LDL cholesterol? The reason I'm asking is the memory molecule is cholesterol, the major memory molecule. In all our cerebral cortex 6 layers, the richest molecule is cholesterol. It remains inert for 30 years. So if you are talking of reducing it to how much, and are you sure it will not affect the brain?
Yeah, so if you say that like hunter-gatherers, where from their remnants and from their whatever skeletons, whatever is available, what we have found is that they had LDL levels of 50 in those days. So if you go by this theory, 7 gram exposure with 40 or 50 milligram exposure every year average, that would probably go to 100 and just do the math, 5 grams at 100 years or 4 grams at 100 years. So by 180, you will get 7 grams. So that is fine. Now the problem is that is natural. You have 40 or 50 milligram naturally, and now you are adding medicines to suppress it. Is there any difference? That is something we don't know. And we in medicine, we know that someone who naturally has arrhythmia-free ELR, and someone who has arrhythmia and you give him medicine and make it arrhythmia-free, is there any difference? Yes. So inherently, somebody is now built to have that kind. So it's exactly like people who say drink red wine, or people who are carefree. So do they get their health benefits from drinking red wine, or because of their nature, which is gregarious, which is more sociable, which is more happy kind of? So what comes first? We do not know. So we need to look into this at a great depth. But what I mean to say is this is very thought provoking. When Braunwald gave this talk in 24, in fact, January 24, it was very, very insightful.
Yeah, Yash, but the human brain and other organs, even including adrenals and kidneys, they manufacture their own cholesterol locally. These organs are really not dependent on circulating levels of cholesterol. That is number one. Second thing is, we all know that our umbilical cord level of LDL is 30 mg/%. So you are sent on this planet with a LDL level of 30. Then XYZ happened, McDonald's happened, and Kentucky chicken happened, and everything happened. And then you got the LDL of 160. So then, as he said, if you maintain your LDL levels of 50 from the age of 20, you will get your ASCVD threshold at the age of maybe 80, 85, if not 100. So I think that the point you've taken is very, very valid, but this is the logic that, and majority of the PCSK9 trials, even after the trial has ended, they have followed up patients. And there was no real cognition impairment or dementia or all that. And even if they happened, the placebo arm had a similar incidence. In fact, in the aliricumab trial, the placebo arm had a higher incidence of dementia than the treated arm. So I don't think that that's a real.
And with the concerns with statin of cancer, of high sugar levels, of intracerebral hemorrhage or intracranial hemorrhage, and the violent behavior. All these things, most of them are found not to be consistent across the studies. And the other thing is that if you talk about all-cause mortality, finally, that wins. So maybe there is slight increase in the sugar levels, but you are getting to live a longer life and a better life.
It's not because of the use of statins which will produce that is why ezetimibe has a role. So it's better to use ezetimibe with statin rather than statin.
Yes, you're right, probably, and for several reasons. And another reason is that the combination therapy gets you to the goal more quickly and with less effort and with less side effects. So that's why we are talking more and more about combination therapy right now. I would still take LDL variability with a pinch of salt, because LDL variability can happen because of so many reasons. The patient may be forgetting to take the statin. Patient's lifestyle as he grows older may be becoming more inactive, or maybe stress levels are changing. So many other factors which we have not accounted for LDL variability. So I think we need many more studies on that.
I think with the paucity of time, we
Thank
might
you.
have to conclude the
Thank
session.
you very much, Dr. Samir Dani. And I request Dr. Unarkar to felicitate Dr. Samir Dani, and Dr. Tarun Madan, is going to felicitate all the chairpersons, and Dr. Sanjeev, please felicitate all experts.
Dr. Nehal Sadhu, please come on the dais, and Dr. Harshad Bhai. Dr. Harshad Bhai and Dr. Nehal Bhai, please come on the dais.
Good evening, all. On behalf of Ahmedabad Physician Association, we would like to appreciate the organizing committee and the team of ACS. They are doing extremely good summit every year, and this time also. So I would like Dr. Harshad Patel to join me and all the organizing committee, Dr. Jay, Dr. Tarun, and Bhupesh Bhai, and all. Please.
Request all team members to be here, please.
Without further delay, I would request our next chairpersons, Dr. Bhupesh Bhai, to come on the dais, Dr. Anand Shukla, Dr. Gaurav Panchal, Dr. Dhruv Jadeja, please chair the session. Experts in the same session, Dr. Bhargav Patel, Dr. Kunjan Shah, Dr. Kirti Patel, and Dr. Kruti Rajvansh. I would request Dr. Anand Shukla to invite our speaker.
Good evening. Dr. Somu, we are working together since long. He is a staunch academician. We learned the abnormal ECG despite of doing the DM. There are certain things always we eager to learn from him. So the Somu Bora is also an associate professor at the UN Mehta and is a senior electrophysiologist and device specialist. Dr. Somu, please.
Thank you for the kind introduction, respected chairpersons, discussants, senior faculty members, teachers, and colleagues. After hearing the scenarios, the master talks by everybody here, I feel humbled to be standing in front of you, not because I know more, but because I have listened more than what it is there in store. And everybody said it right. Coming to a conference to gain knowledge and reading from a computer is something different. You can gain a lot of knowledge from the computer itself, but listening to experts and gaining their wisdom, so listening to their wisdom gives you knowledge to help you gain wisdom in your practice, and that's what the key would be. And also the camaraderie of all the people here will increase the lifespan, I suppose, as told by Dr. Hiramat. So with that words, I'll start. Bradycardia, I think the lesser the heart rate, more the lifespan. But why do you want to treat it then? You should not treat it, right? So unless the patient is symptomatic, you don't treat sinus bradycardia. Unless the patient has problems, you don't treat. So my talk would be divided into three major parts: case scenarios and recent advances, and a takeaway message. True bradycardia is only sinus bradycardia and AV block. You cannot have bradycardia because of anything else. Pseudo bradycardia in the current world is because of all the digital devices. It can be APC driven, VPC driven, under sensing of your smartwatches causing bradycardia, sensing the sleep bradycardia as pathological bradycardia. So all those things put together make you a little bit tense. Pathological bradycardia is what we treat if the patient has symptoms. So a typical case of bradycardia, sick sinus syndrome in the elderly since long, and with a normal echo, the patient comes to you with symptoms, you treat that. A patient with AV block, here is 2:1 AV block, no chest pain, normal echo, occasional giddiness, so symptomatic bradycardia, you treat the patient by a typical pacemaker, single chamber pacemaker, double chamber pacemaker, or if LV dysfunction is there, a CRT, right? That is how we treat, general. So what is the challenge? Why do you want to have that challenge of getting into bradycardia? 90% of cases are these typical cases. Normal routine clinical practice is 90%. So I was given a challenging topic. So I'll put in the case scenarios. What is the challenge? So what causes bradycardia? Is it degenerative or is it something else? What are the treatment that can be offered in bradycardia, and what is the type of device in the current scenario that you have? So let us see in case presentation that come to your clinical practice. This is a patient who presented with symptomatic bradycardia since last 5 years but not wanting to get treated. Ejection fraction was 45%. There was pulmonary artery hypertension, restrictive cardiomyopathy possibly, and patient had symptomatic failure. So what do you do with this patient? You will say, put in a pacemaker, right? Simple, straightforward. So doing a Holter, get some idea of the average heart rates. Doing a cardiac MRI possibly would tell you that this is the cause. But however, the patient has symptoms because of bradycardia, so you want to do a pacemaker. So why to evaluate further would be to decide on what kind of pacemaker. And so the treatment options in this bradycardia was what to do. So whether to give a single chamber pacemaker with normal routine septal pacing, with a conduction system pacing single chamber pacemaker, or a single chamber pacemaker with atrial pacing, or a double chamber pacemaker in the similar fashion, or a CRTP. So what do you suggest? Seeing the history of this patient who has atrial fibrillation, bradycardia, what would you want to give? So think that atrial fibrillation is there since long, you don't want to pace the atrium at all. So obviously you have to pace only the ventricle, and if you are pacing the ventricle with an ejection fraction of 45%, with the septal pacing, you might worsen the LV function. That is what people have shown over trials, wherein wider the QRS, the chances of LV dysfunction is higher. So what is conduction system pacing? And I'll just give you a purview of that you try to pace the conduction system itself. You pace the His-Purkinje system either at the level of the His or below that at the left bundle or near the higher septal, where you can capture this His-Purkinje system easily, and that will give you the normal conduction that happens via the normal system. Normally, if you are pacing, you will be pacing in the RV apex or the septum mid. Rather than that, you are pacing at the conduction system, and we use special hardware, and you need to have special techniques for that, and preferably a 12 lead ECG during the implant. So for this patient who needs a pacemaker, most of the time, if you do a pacemaker in a patient who has an ejection fraction less than 50%, what is recommended is you do a conduction system pacing or a CRT rather than a typical pacemaker. So that is one thing that you should know as a class 2A indication. In atrial fibrillation, similarly, if you do a AV nodal ablation, or if you have bradycardia, a conduction system pacing or a CRT is advisable. So what is conduction system pacing? Just a single lead here put in the septum and you will see the outcome. This is the own rhythm, and we started pacing. It hardly has a difference. It's narrow, complex, typical. It will give you a very good normal looking narrow complex with good stable output. So over 3 years, this remains the same, and the patient ejection fraction has not worsened. The pacemaker is working fine, and With a single chamber, you are able to achieve what CRT would achieve with 3 leads. So that is the cost saving also. This was way back in 2012 when the ejection fraction in this patient was around 50%, treated as primary pulmonary hypertension, bradycardic, no P wave seen, and this turned out to be atrial standstill. The heart rate would not improve, the atrial was stiff, and that is why pulmonary hypertension was there. We just did a CRT in this patient with the RV and LV lead, and the patient, we did a PG change in 2021. She is now 80 years old. Otherwise remained symptom free. What she was functional class 3 is now functional class 2 over the 10 years of her aging. Going on to the next part would be AV block. So if you have an AV block, you put in a double chamber pacemaker and you are done. But if patients have ejection fraction which is around 50% or low, if you have an LV dilated and dilated heart with a valve regurgitation, better is to do physiological pacing, and that is where conduction system pacing again comes. A double chamber pacemaker, if you do, the outcome looks like a normal conducting person only. So that's very important to get that the LV doesn't dilate it. So now I will get to the next part. What after conduction system, what comes? So if you have a patient who has palpitation and along with that fatigue, you have tachybrady syndrome, you have one place tachycardia, one place bradycardia, what would you do? Normally, the options would be give antiarrhythmic medications and see that the tachycardia doesn't occur. But if you give antiarrhythmic, the bradycardia will be more, right? So then people would say, no, give a pacemaker and then give medications. But how guaranteed you are to treat the patient of tachycardia with medications? So therefore, the role of ablation comes here. We treat the patient with tachybrady syndrome. If it is ablatable, we treat with ablation first. And in this patient, we did a 3D map, showed that there was a scar. So the gray part was all scar in the right atrium, and the colorful part that you see were scar areas a little bit, and we treated the patient for tachycardia. After tachycardia was treated, he continued to be in bradycardia, 45 average heart rate. He was advised a dual chamber pacemaker just because he had a scar and the chances of recurrence of tachycardia was there. But he was reluctant because now the tachycardia settled, bradycardia is well tolerated, and therefore he continued for 2 years on dabigatran and derifylin to keep his heart rate up. Again in 2024 he presented with palpitations, and that is where he again had symptoms. So echo was showing mild more RA dilatation. We wanted to see an MRI. MRI showed no LG. So now again what do we do? Now give a pacemaker or again go for an ablation? So main problem is tachycardia. I want to treat the tachycardia, so I went again for an ablation. And if you see, the scar has progressed and the RA has dilated much more than what it was before. So this is a progression of disease. And if you see, there is no living muscle in the whole of the right atrium. So suppose if I would have done a pacemaker, it would not be pacing now the right atrial appendage at all because there is no signal in that area. There would be no pacing at all in the atrium, and I would have ended up doing a ventricular pacing in this patient. So there is no capture at all in EP study, and the average heart rate post ablation was around 42 only. So we did do a pacemaker, dual chamber pacemaker, but no atrial pacing. Therefore, we had to do a left atrial pacing. Left atrial pacing was done by a epicardial pacemaker put on the left atrial appendage. So it was a simple procedure, 45 minutes of thoracotomy, and this will give you more insight as to how to approach, because many a times you will say, no, the lead failed. No, it's not the lead failed, it's the disease which progressed. Coming on to the other part, wherein you need to find out what is the cause, very important. So, garden variety complete heart block, but in a young patient, 52. Why should a 52-year-old have a complete heart block? And that too with trop positive and angiogram being normal. So, something wrong has to be there, and that wrong has to be seen. But if a patient has long pauses with pre-syncope, our reflex is to put in a pacemaker. So we did see the echo, we saw that there was no RWMA, no chest pain, and we did put in a pacemaker, but evaluation further we did, and what did we find? So after discharge, it was very important to say, no, we need to evaluate further, and that evaluation led to a PET scan which showed that there was an uptake, abnormal uptake into the myocardium in the infralateral area, suggestive of possible sarcoid heart disease. Now, I would have treated by a pacemaker, but the sarcoidosis is not treated, right, by pacing, and that's very important. Managed with steroids and methotrexate later on, and after 3 months, there was no uptake at all. So treating the disease per se is very important, and the next example will show you why. Again, a 28-year-old presenting with complete heart block or high-grade AV block, symptomatic but not wanting a pacemaker. We evaluated, PET scan was positive, again a single nodule there. We asked him to get a pacemaker done, but he was delaying again and again. But if you have patients who have not been put in a pacemaker and you want to plan this patient a pacemaker, the recommended therapy is a dual chamber ICD. Why? Because sarcoid heart disease can cause ventricular arrhythmia itself. And no matter, we could see in this patient itself that he did not agree for an ICD and we put in a pacemaker. Echo was still normal, but he had VT on the patient's follow-up. So he had a clinical VT on a patient on follow-up. We did a PET scan again. PET scan showed increase in the uptake. We had advised steroid, but then he said, I did not take steroid because it was my marriage that time. So he did not take steroids. He failed to take the treatment for sarcoids and he ended up with a VT. So if you don't treat these patients early enough, they end up having more disease and later on they also may develop LV dysfunction further. So this was a patient who had a pacemaker done, EF was noted normal, everything evaluated, was then noted LV dysfunction within 2 years. Ejection fraction had decreased to 35% on follow-up. And if you see the PET scan, the whole of the anterior wall was showing an increased uptake. By the time we intervened by doing a CRTD, the damage was done and the ejection fraction still remains at 35%. So very important to see the cause rather than just see why the patient has had bradycardia. It's very important to see the cause. In a young lady, 52, weight loss as a typical feature, fatigue can be there. But if you see ECG characteristics, there is T-wave inversion. So these T-wave inversions are abnormal for a sinus bradycardia per se. So that is AI. By experience, by seeing more patients, by seeing their follow-up, you gain much more knowledge. And that is what helps you to treat those patients. And we did a MRI which showed an infiltration here and a PET positive, but she had a breast nodule also. It turned out that the patient had a breast CA with metastasis causing the sinus bradycardia. So the first presentation of sinus bradycardia was this breast metastasis. She had flutter, she had loss of pacing later on, and she eventually did not make it this last year itself, but then we could diagnose what caused the problem. Another lady, again diagnosed to have 6 sinus plus AV block, and she had a pacemaker done. Ejection fraction decreased to 35% over a period of 1 year. It was considered that you have paced and therefore LV dysfunction has set in. So she also had atrial flutter, and if you see that pacing interrogation had continuous flutter. Referred for ablation of flutter as well as treatment to upgrade to a CRT. Now we did a PET which came to be normal, but ESR was very high, 98. Did a ANA profile which showed high values of SSA-RO, and then just steroids were given for the patient and ejection fraction improved immediately. So rather than CRT, just a steroid dose for this SLE treated the patient. Again bradycardia treated for referred for pacing and had syncope and sweating and vomiting, and we did the HUD test which was having a long pause. So how many would put a pacemaker in this? I think everybody agrees that everybody would. But what is more important is the tummy here of the patient, and if you see that with bradycardia and Holter, and if you see the Holter recording, it's all night time between 10 o'clock and 4 o'clock in the night, where there were long pauses, and that was classical of sleep apnea. And if you treat sleep apnea, 2001, that was the presentation, 63 heart rate. He continues to be on follow-up till 25, last follow-up 17th, yesterday only I suppose. And CPAP and weight reduction, these are the two things. No symptoms, no pacemaker, continues to be fine. So treatment of sleep apnea treats the patient symptomatically rather than treating the bradycardia itself. So very important, whom to evaluate for secondary causes are females, acute history, patients who have abnormal brady as well as tachycardia, systemic features are there, skin lesions are there, patients who are obese with sleep apnea and high inflammatory markers, they should be evaluated further. A word about the guidelines. Guidelines are there, but you don't know them. So there we know anybody with less than 60 years with AV block should be evaluated by at least a CT scan, if not by MRI or a PET scan. So it's very important, and these are part of the guidelines. So genetic testing as one more part. Bradycardia, 6-year-old boy diagnosed as long QT, just treated with propranolol. So bradycardia treated with propranolol because the patient had long QT causing torsates, causing syncope. You would have thought that bradycardia was causing the, again a patient, again 15-year-old boy, treated as sick sinus syndrome, multiple years of evaluation, bradycardia persisting, symptoms persisting, and Holter showing long pauses, thought to be post-viral sequelae, and MRI also done, which did not show any sequelae, and again Holters were repeated. But finally, you should understand that long-standing history in a young person can be genetic in nature. And when we asked for genetic testing, especially that SCN5A and Desmin, it came out to be SCN5A mutation. Now, when you have this mutation in this patient, you know that this is a progressive disease and the treatment should be accordingly rather than a post-viral disease. So, knowing why this happens is very important to further answer these questions, whether it will progress and what kind of pacemaker the patient would require, because it will progress, the atrium will get burnt out and you might require a conduction system pacing in that. One more patient, young patient, see epilepsy in children and not getting treated is a arrhythmia underlying, and that is where this child was there, 2:1 AV block. We did a pacemaker with AV block, but post you can see that there was ventricular arrhythmia, and even after that the patient unfortunately had a demise. Why? Because the patient had a myosin heavy chain mutation, which was not recognized before putting in the pacemaker. We could have put in an ICD itself. So it's very important to evaluate well. Similarly, a post pacemaker patient develops ptosis and has a Desmin mutation, very important. So these are patients who will present with atrial flutter and LV dysfunction later on, and you need to put in a CRT. Lastly, these advances in bradycardia therapy. If you have patients with infection or a closed venous system, you can go in for an endocardial with venoplasty. You can do from the femoral vein. You can go transhepatic, you can go transjugular, but what is in is the leadless pacemaker, which can be implanted through the femoral, and it's a battery operated small capsule type which goes into the right ventricle, just paces down, and it is now in a VDD format as well as a double chamber format. You can pace the atrium well, you can pace the ventricle both simultaneously. Indications being infection, subclavian stenosis, so lead access is not there, and tricuspid valve disease as the major indication. And for FADS, physician choice, people say no, I've done a leadless pacemaker. So advantage and disadvantages are there. Problems are also there. There is what we call as a vice CRT, so you implant a capsule somewhere and it ablates. Last, about home monitoring, bradycardia treatment, you can monitor without going to the hospital. You can do it on your mobiles, and mobile connected pacemakers are there which will transmit all the data to your treating physician, and then they will say it's right or not. So summarizing, bradycardia is treated easily by pacemaker. Most of the cases do not have secondary causes, and mind you, 90% don't have secondary causes. Only 10% will have to be evaluated, and especially young patients are to be evaluated well. Knowing the secondary cause is important to go further as to how to treat them in the future as well as which device to be given, and indications of these devices should be known well, especially the leadless and conduction system pacing, rather than do it in all. Thank you.
Thank you, Dr. Shomu. That was enlightening talk. Question and answers, please.
The commonest question is when we have to consider the permanent pacemaker after the MI, particularly inferior, because even after the revascular, sometimes the conduction disturbance persists.
So, first thing is to know the acute MI caused the CHB. So, prior patients may have asymptomatic complete heart block and we may come with MI. That also happens, and we have seen many cases like that. If it is diagnosed that the MI caused the complete heart block, 7 days is the time that you give. Inferior wall MI recover most of the times. You may give 10 days, 14 days, they'll recover. Anterior wall MI, if you don't pace, they are hemodynamically unstable. And most of them should recover within 5 to 7 days. If they don't, you need to give a device. If you have ACS, by TROP positive, RWMA, chest pain, angioplasty first, because if you revascularize, it will recover. If no chest pain, TROP negative, you have repeated it, no RWMA, pacemaker first, because the moment you do angioplasty, you will not let us do the pacemaker. The reason is you will give a lot of heparin, lot of antiplatelets, and the moment anything happens, you will say that hematoma हो गया तो क्या करने का, या तो infection हो गया तो क्या करने का, and stent बंद हो गया फिर तो. So
how often you see in conduction system pacing the degeneration, like especially degenerative AV block, you can pace the conduction system pacing, then advance the conduction degeneration, and then you have to reprocedure again.
So the data of conduction system pacing is not there much. It is just 10 years down the line that initial studies were done, and major data is coming just 4 or 5 years. So long-term data is unavailable. It's just simulated data that is available. The problem is if you are pacing the left bundle and it degenerates distally, will it cause some problem? That is the question I think you are. So yes, it will cause, but you are pacing deep in the septum. So deep in the septum means you are occupying a larger area. You will still pace, but you may not have the narrow complex. So that would be the only difference. So you will not lose pacing, but you will not have narrow complex over the period of time. And that we have seen over a period of 2 or 3 years, wherein that narrowishness goes away and it seems to be broad, but then it's still pacing.
Okay. And then second question, patient with the degenerative AV block, do you do the angiography as a defaulter?
No.
Because nowadays not
No.
many patients the angiography first, triple vessel disease,
No.
go for CVG,
No.
then pacemaker.
No.
Okay, so
Again, see, electricians and plumbers are two separate people. You can have short circuits because of plumbing problems, and you can have fires which need plumbers because of electrical problem. But if you mix both, it is becoming problematic. So what the patient has is a problem, you treat that rather than create a problem and then douse the fire. No.
even Ayushman card, they are asking angiography report first.
No. We have tried not to do that. So, no.
So I have one question. It's not very usual, but if the patient has a triple vessel disease and patient has undergone a pacemaker, how long should we wait before subjecting that patient for the bypass surgery?
Stable patient. Stable patient, 1 month at least. The problem is, what is your surgeon doing with the heart? How much he's moving? The lead needs to mature for at least 1 month, preferably 3 months. If the surgeon is moving significantly, the lead may actually get dislodged and you may need to do a reprocedure. So if a patient who is not an urgent candidate for a pacemaker, first do a bypass surgery, wait for 7 days and then do the pacemaker rather than otherwise. If you have to do a pacemaker first, wait for at least 1 to 3 months.
And anterior wall MI who will subsequently require a pacemaker. So is this particular patient likely to also go for a tachyarrhythmia in the procedure? And would it be advisable to put an AICD with the PPI or just a PPI?
It is depending on ejection fraction. So ejection fraction, if it is less than 35% AICD, if you know that it is not going to recover. So the moment you have an MI, you have a scar, you know that this patient has a QS pattern on ECG, the wall is not going to recover, then ICD if the ejection fraction is less than 35. If it is between 35 and 50%, people do say conduction system pacing, but not with the anterior wall MI septal scar.
And this patient would likely go for a tachyarrhythmia because of the bradycardia or the low heart rate going on from the ventricular complex or something.
Brady-induced VT is common in these patients. It's not uncommon. So in those patients who have Brady-induced VT, you need to pace faster.
Okay.
Now, whether to give an ICD or a pacemaker will depend on the clinical situation.
Okay. Thank you.
One last question from ma'am, and then we can conclude the session.
Thank you. So a very common scenario in OPDs is elderly patient coming up with just fatigue, and when you do an ECG, it's a 6 sinus type of picture. So would you pace such patients, or you just go for a halter and decide, how it is?
6 sinus
Because
is,
fatigue, there's no giddiness, there's nothing else.
So US में fatigue is functional class 3, while India fatigue is functional class 1, as I understand. Because you have a lot of people who can help you out in your daily course. You can sit down, relax and enjoy. While in US, people have to do their own work. So they are functional class 3 with fatigue. And in India, you can be functional class 1 with no fatigue at all, with sinus bradycardia persisting throughout your life. In fact, I have a patient who has CHB with a rate of 40 and he's functional class 1 because he says, બાકી બધું કામ તો મારું બધું થઈ જ જાય છે. મારે ચક્કર નહીં આવે ત્યાર સુધી વાંધો નથી. So, if you have giddiness, if you have syncope, that is the time you need to be urgent about it. 6 sinus generally will have fatigue. If their quality of life is less, if they say that I want to be better in my quality of life, offer them a pacemaker if they are ready. Otherwise, you can offer them derifylin, maybe ocryprenalin to a certain extent. You don't say that pacemaker नहीं डलवाते हैं तो मैं तुम्हें treat नहीं करूँगा. ऐसा तो नहीं करना चाहिए.
Yeah, but derifylin, is it recommended for?
Yes, absolutely.
Absolutely.
It's a
Yes.
Yeah, okay, thank you.
Thank you so much, Dr. Shomu. I would request Dr. Bhupesh Bhai to felicitate our honorable speaker. Dr. Shomu, please come on the stage once again. And then would request Dr. Bhavesh Thakkar to acknowledge our chairpersons and Dr. Utsav Unarkar to come on the dais. Dr. Bhavesh Thakkar to felicitate Dr. Gaurav Panchal and Dr. Utsav Unarkar to felicitate our experts. For the next session, I would request Dr. Nalin Ghiwala to chair the session. Dr. Hitesh Patel, please come on the dais. Dr. Shaurin Upadhyay, Dr. Darshana Makwana, please chair the session. Dr. Bhavna Patel as expert, Dr. Siddharth Shah, Dr. Mehul Shah, and Dr. Bhav Singh Parmar. For this session, I would request Dr. Bhupesh Bhai to give a talk. What does the future hold for the management of heart failure? Dr. Bhupesh Bhai.
Start because good evening, seniors and friends. I know that after these many lectures, we need to know how to live 100 years before developing, because there are so many lectures, heart failure and ischemic heart disease and so on. And it is also good that I should not stand between the good dinner and this lecture, so that, stress is also reduced. But the paradox of the coronary artery disease is that coronary artery disease rates which are down by half, but heart failure is almost triple. That is something worrisome, because the burden of the heart failure which has increased. And another problem is, we can see the decline in the mortality, heart failure mortality, but again after 2011, the mortality in heart failure has started increasing. And HEPREF, MREF and HEPF, if the pro-BNP level, anti-pro-BNP level is very high, as we can see from this slide, last bars if we can see, then mortalities again, it is almost similar. So heart failure with MREF and PEF, that is the preserved ejection fraction heart failure, so persistent high anti-pro-BNP level, it also gives a lot of mortality to the patient. And as a result of which, this is the classification, HEPREF, MREF and the HEPF. This is mainly for the MREF and the heart failure with the preserved ejection fraction. Treatment of the MREF, that is class 2B indication for the MRS, and American, European, both they have agreed for that. But in case of HEPF, we know that American guideline class 2B, but European guideline still it is not saying anything. And this is important, that is variation in the incidence of the rate of the deaths by the cause and continuous left ventricular ejection fraction. If you look at this slide, as the ejection fraction which increases, the non-CV death which increases, but ejection fraction is on the lower side, that is the HEPREF, the sudden death which has increased. And obesity, which increase the risk of the CV events in the absence of metabolic abnormalities. And as previous lecture, this was regarding the CKD and the heart failure, because albuminuria, which is very, very important. And this is mainly our focus is on MREF and the HEPF. There is the high unmet need for the patient with the heart failure with LV ejection fraction more than 40%. Including the high hospitalization rate and the mortality, we know that now rising prevalence of the HEPF patients, there is poor prognosis too, and they need hospitalization, and the recurrent hospitalization we see in so many patients. The life expectancy is reduced. For example, patient is having diabetes, 6 years is reduced, diabetes with CV disease 12 years, but CKD, that is 16 years it is reduced. Coming to our important molecule, that is finerenone, but fidelity, the primary analysis which showed the significant risk reduction in the CV and the kidney outcome with the finerenone. There was 14% reduction in the CV morbidity and the mortality, and 23% reduction in the CKD progression. And whatever the effects which was seen with the finerenone, that was irrespective whether patient is on SGLT2 inhibitors or GLP-1 agonist or not. It was benefit was reported. In this fidelity trial, it was found that finerenone, actually the BNP level which was very low compared to those who are on placebo, and troponin level was also found little less. So finerenone, which improved the cardiovascular and the heart failure outcome versus the placebo in the patient with the CKD in type 2 diabetes. And after this, of course, this was mainly driven by the reduction in the hospitalization of the heart failure. And as a result of which, we know that in type 2 diabetes with CKD, SGLT2 inhibitors, class 1A, and the patient is having diabetes and CKD, finerenone was recommended to reduce the risk of the heart failure hospitalization, which was class 1A. So this is now proven for the diabetes with CKD. But this is another recommendation, that patients with diabetes, they are routinely screened for the kidney disease by assessing the eGFR, and we have to know the USCR in this patient. And we know in MREF and the HEPF patient, the SGLT2 inhibitors, which is very, very important molecule, but still there is residual risk which is there. If you look at the Emperor Preserve trial and the Deliver trial, I mean, residual risk is still there. So again, I will say that it's an unmet need. How can we further improve that. There are limited approved treatment for the HepF patient and MREF patients, but only few, I think, diuretics, the SGLT2 inhibitors. RNA again, it is MREF patient, which is important, but still we have not the full period treatment as like in HepREF patient. So this was the trial, which was the fine arts heart failure study. The patient having the symptomatic heart failure, ejection fraction 40 or more than that, hospitalized, recently hospitalized, high natriuretic peptide levels and the structural heart disease. And here the finerenone was given in little high dose compared to this previous Fidelity trial and the Figaro trial. Here it was increased up to the 40 milligram according to the eGFR of the patient. And the randomization timing that is relative to the most recent worsening the heart failure event and the LVEF status on the randomization means the 20% of the participants were randomized during or within 7 days of the worsening heart failure events, and the LV ejection fraction status, as we know that 45% there between 50 to 60, less than 50% it was in 36%, and more than 60 in the nearly 20% of the patients. And the primary endpoint, that was CV death and the total heart failure events, it was in the favor, and the 16% reduction was found. Rate ratio was 0.84. So, I mean, better results with the finerenone, and it was not related to any male or female. It was equal whether patient is on the SGLT2 inhibitors or GLP-1 receptor inhibitors. This is very important slide that hyperkalemia and hypokalemia both are very, very important in any patient, but we know that hypokalemia, which is more dangerous than the hyperkalemia, and by putting the patient on the finerenone, hypokalemia was less. Though we have to be careful when we are putting any patients on whether it's steroidal or non-steroidal MRAs, we have to check the potassium, but here the chances of the hypokalemia was less when the patients were put on the finerenone. Comparison of these three molecules, spironolactone, eplerenone, and the finerenone, we know that spironolactone usually we are using for the resistant hypertension because it has long effect, it lasts for the 3 weeks. Eplerenone usually used in the acute myocardial infarction status, but finerenone is the molecule when the chronicity which comes into the picture, where finerenone which works very well, and as a result of which it is the treatment of the choice when the patient is having the CKD, patient is having the heart failure, MREF and HepF, because when the chronicity which comes into the picture, I think finerenone which works very well because it has equal effect on the heart and the kidney compared to other two molecules. And these are the changing landscape of the heart failure pharmacology. We can see the various trials. In the previous trials, RNA was not available as SGLT2 inhibitors, they were not available. So this was the fine heart umbrella program, and pulling all this data together, we can see that primary endpoint, that cardiovascular deaths, which was reduced, cardiovascular death, including the undetermined death, which is reduced. So the patient is having the MREF and the preserved ejection fraction. So we have one additional treatment. Now question arises, the why death is not being much affected. If you look at the previous trials of 90s or 2003, and you look at the trials of 2021, already mortality has already reduced by the 50%. So it is very difficult now for any trial to show that there is greater benefit in the mortality. Another subgroup analysis with the finerenone was that significant benefit which observed within the 30 days of the initiation of the finerenone, which we can see in this trial, and estimated long-term benefit of the finerenone, that is, if the finerenone which is prescribed to the patient having the MREF or the HepF, we can see 3.1 year lifespan the patient may get. So survival free from the primary endpoint of the 55 years. This is the estimated long-term benefit of the finerenone. And as I told you that finerenone has got a combination with the SGLT2 inhibitors, I think in the future, maybe in the heart failure and the CKD patients. Barriers to implementation, according to the doctors, usually when the knee jerk is that whenever the patient is on MRS, immediately we stop first in the majority of the patient on this survey. And hypotensive patients, if you look at this diagram that patients are having the blood pressure in the range of 105 and 115. There was no much difference in the blood pressure. Means the patient is having the blood pressure on the lower side. It is not going to create much of the hypotension. So that's why also it is going to be very effective. So rationale of this molecule, despite the availability of the several therapeutic options in the heart failure with mildly reduced and the HPF patients, including SGLT2 inhibitors, but still there is unmet need. Steroidal mineralocorticoid receptor antagonist reduce the morbidity mortality in the patient with heart failure with reduced ejection fraction, but their efficacy in the MREF and the HPF patient has not been definitively established. So this is the important trial, fine arts heart failure trials, where the finerenone, one more molecule that we can say now 3 pillars for the treatment of the heart failure with the preserved ejection fraction. So I think in the guideline future, we may see the finerenone, whether it may be class 1B. And another, there's semaglutide, because all preserved ejection fraction, whether it is obesity and obesity related, it's a metabolic disease. So semaglutide and the tirzepatide, which is altogether, it's a different topic, but still I think these are the two important drugs I think we are likely to see in the future guidelines where the patient is having the MREF and the HPF. So take home message is whatever it is that when the heart failure comes into the pictures, we can say it's urgency of doing. And why we are not getting the good result? Because we need to have the right way to design the trial, to find the right patient, then right time also when to give the drug to the patient. We should have the right composite and non-composite endpoints, and the endpoints to have the enough power to detect what we want to detect. And that is the story. I think this is the one more molecule. There are 3 pillars for the HPF. Thank you very much.
Thank you so much, sir. And would request the next speaker, and after that we will take the questions. Dr. Sanjeev Prajapati to present on what does the future hold for management of resistant hypertension. And I would request Dr. Bhav Singh Bhai to join the session as a chair.
Hello, good evening. So we are at the end of our journey for the first day, and we have seen very great lectures. At the end, I'll just go through the resistant hypertension. There are 2 subset of patients, or we see usually in OPD, that one patient came with an accelerated hypertension, which is on our regular follow-up. Patient is already on multiple medications, but still patient is not having good control of hypertension. We do 2 things. Either we say that it is more of an white coat hypertension. Every time patient comes to our hospital because of white coat effect, patient is having hypertension, and we will not treat that patient. And at the end of 3 to 6 months, we see the same patient at our emergency as in heart failure with preserved ejection fraction. So it is more often going for patient because of not treating properly hypertension, resistant hypertension, going for heart failure with preserved ejection fraction at the end of 6 months. And other subset is the same patients, because of white coat effect is there, we are increasing the dose of hypertension at every time which is patient is coming to our follow-up, and every time we are increasing the dose of our antihypertensive medications. And after 2 or 3 days, patient come to our hospital at the emergency department with the syncope. So 2 things are there. Either we are under-treating the patient, or we are over-treating the patients. In these 2 things, only one thing is missing, that we are not educating the patient, and we are not taking the good help of, which is presently very nicely available, which is an ambulatory blood pressure monitoring device. So at the end of this discussion, at least we'll have few newer molecules. So possibly in another 2 or 3 years down the line, we'll have few molecules which will be available to treat our resistant hypertension patients, as well as intervention therapy at the end of this session. So as we know that there is a very global prevalence of 5 to 10% global prevalence of resistant hypertension, as we see, which is more concentrated in our India because of high salt, which is more of a double, which is 10 to 12% of global Indian prevalence of resistant hypertension. As we know that because why it is happening more in India, it is mainly because of decrease in awareness and because of because of inertia to treat the patients for the hypertension, inadequate access as well as affordability to the healthcare system, and increased dietary sodium level. So as all the guidelines have already mentioned that it is hypertension which is not being controlled, but because not getting control less than 130 by 80 millimeters of mercury or 130 by 90 millimeters of mercury with more than 3 medications at the optimal dose with good medications, no white coat effect, and optimal dose has to be there, and one of them has to be more often diuretic therapy has to be there. If despite of these all medications and with good compliance, if you are not getting control of that hypertension, then yeah, definitely we stamp it as a resistant hypertension. Before stamping this as a resistant hypertension, as we have already mentioned that what is true and what is pseudo-resistant hypertension. So pseudo-resistant hypertension, there are contributing factors like improper BP measurements. If patient is very obese and we are using a small cuff, there will be a BP fluctuations, white coat hypertension, under treatment, taking a wrong medications or wrong doses, stiffening of the arteries and not following the lifestyle advices. So patient is taking more salt diet, because of that patient is having resistant hypertension. So why we need to see the pathophysiology? We know that more often sodium intake, RAS activity, increased sympathetic nervous system activity as well as endothelial dysfunction. Everything leads to, at the final stage, leads to stiffening of the vessel as well as resistant hypertension. Salt and water retention leads to resistant hypertension. So what is an implication? This is a 2018 paper which has divided patient into with resistant hypertension, without resistant hypertension, which says more than 4 lakhs patients were included. So 32% patient with resistant hypertension, increased risk of end stage renal disease goes for the CKD, 24% increases the risk of ischemic heart events, 14% increased risk of stroke, and 6% increased risk of death. So because of this morbidity as well as mortality, it is mandatory for us to diagnose the resistant hypertension and treat it properly. So as we know, this is very nice slide. So if there is a suspicion of resistant hypertension, there is first always exclude pseudo-resistant hypertension. If there is no pseudo-resistant hypertension, then you go for another step, which is in discontinuation or minimize the interfering substance. If patient is already taking NSAIDs, or if female patient is taking any oral contraceptive pills or hormonal therapy, you have to exclude that before stamping it as a resistant hypertension. If that is also not there, then you go for the secondary screening or the secondary causes of hypertension in the form of primary hyperaldosteronism, CKD, pheochromocytoma, or mainly obesity as well as obstructive sleep apnea has to be ruled out. And if finally everything is ruled out and still patient is having persistent more than 130 by 90 millimeters of mercury blood pressure, then we stamp it as a resistant hypertension and we treat the resistant hypertension. So all the data says that every target has been given by the ACCH is also saying 130 by 80. If it is a patient is having associated comorbidities like diabetes as well as CKD, our target is less than 120 millimeters of mercury. So it's a multifactorial approach is there. First is in lifestyle modification, as we already says, as discontinuation as interfering substance. If patient is taking any medications, that has to be stopped. Rationalization of current treatment and the sequential addition of antihypertensive drugs and existing triple therapy medications. So how we step up or how we approach for the medical therapy. So as we know that we start with the medications. If patient is not following lifestyle modification, we always tell to adhere more to the lifestyle modification. If patient is already on lifestyle modification, add on diuretic therapy, maximal tolerated dose of diuretic therapy. If still BP is on higher side, go for an spironolactone. That too often start with the low dose, go to the maximum tolerable dose without getting any hyperkalemia. If despite of adding spironolactone, if patient is having hypertension, you can add on to the central agents like alpha blockers or beta blockers if patient is having angina or heart failure. And if despite of this everything is not getting control, then you go for a newer medication as well as for the interventional therapy in the form of renal denervation. So these are few emerging drugs. These are still in under trial as well as clinical 3 or 4 trial is still on there. So as we have already discussed more for the kidney RAS system, this is a recent molecule or which will come in another 3 to 4 years, which is a firibastate. It is a brain aminopeptidase inhibitor which inhibits angiotensin 2 to converting into angiotensin 3. This is mainly for the RAS activity into the brain. So it has to cross the blood-brain barrier and it has to act on the brain. So if you stop this angiotensin 3, what it does? So angiotensin 3 is not binding to the angiotensin receptor. Because of that, there will be a decrease reduces the vasopressin, increases the diuresis, and decreases the extracellular volume. By that, it reduces the hypertension. It improves the baroreflex function. Because of that, it decreases the blood pressure, and it decreases the sympathetic tone from the medulla. So because of that, there will be reduction in the hypertension. So human phase 1 and phase 2 clinical trials has already finished, and which has shown a significant improvement in a hypertension in a resistant hypertensive patients. So in another future trial, we'll have firibastate for the resistant hypertension. Another very important is an endothelin 1 receptor antagonist. As we already have the macitentan, bosentan, everything is there. This is a similar class of the drug, which is an aprocitentan. This is it's a dual pathway inhibitor, dual receptor inhibitor, ETA, endothelin receptor A as well as angiotensin receptor B blocker. By the end of this, because of producing more diuresis, it reduces the hypertension as well as endothelin. Because of reduces the vasospasm and fibrosis, it reduces the hypertension. So this is a precision trial. It has also shown a significant improvement in hypertension with the aprocitentan, which is similar to that of a macitentan. In a near future, we'll have aprocitentan in a market for the hypertension. This is another an aldosterone synthetase inhibitor, which is an dextrostate, which is an end stage. Every pathway, if you see, consider at the end, it goes to the aldosterone, and this is the main factor for the resistant hypertension. If you stop the synthesis of aldosterone, there will be a reduction in the hypertension. There will be more diuresis, and salt and water retention will be reduced, and hypertension will be reduced. This is the same Brighton trial is there, which has shown a significant improvement. Dextrostate have dose-related reduction in a blood pressure. As we already discussed, more of an inclisiran, this is more of an zilbesiran, which is an inhibitory RNA, which is an interface. By the RNA, we are reducing the liver production of angiotensinogen. At the end of when there is no angiotensinogen, there will not be any angiotensin 2 or angiotensin receptors. So there will be a reduction in the hypertension. This is another trial, which is an ARNI. Nowadays, we are using an ARNI for the heart failure, but now because of Paramount trial, which says that even if in resistant hypertension, we can use ARNI as an hypertensive medication with a preserved ejection fraction also. Not for the heart failure, but to treat the resistant hypertension, yes, we can use ARNI for the resistant hypertension. This is an orsidurone, which is a non-steroidal mineralocorticoid receptor antagonist. This is a blockade CKD trial, which was used for in a CKD patients, which has significantly reduced the hypertension without producing an hyperkalemia. And as you know, there's nowadays it's an interventional therapy for resistant hypertension, which is a Medtronic Simplicity catheter is there, which is a spiral catheter for the renal denervation therapy. All the sympathetic activity and hypertension is mainly because of the renal artery sympathetic activity. So if you do the denervation of the renal artery by the Simplicity catheter, there will be a reduction in the hypertension. So this is a Simplicity 3 trial for the renal denervation therapy, which has shown a significant and sustained reduction. So even after the renal denervation, there was a sustained reduction in hypertension for a prolonged period. So renal denervation therapy also can be given for the resistant, very refractory and resistant hypertension patients. This is not very much used, just for the experimental purpose. This is a Barostim Neo, which is for the carotid stimulator, baroreflex activation. When you activate the baroreflex, there will be a reduction for the hypertension. That also can be used for the resistant hypertension. So at the summary, uncontrolled blood pressure more than 130/80 is considered to be as an antihypertensive drug. With persistent hypertension more than 130, we stamp it as a resistant hypertension. And novel agents like aldosterone synthetase inhibitor, sodium glucose cotransporter also can be used, as well as renal denervation also can be used for the resistant hypertension. Thank you.
Thank you so much, Dr. Sanjeev. I would request chairpersons and experts, if any questions are there. Dr. Jay, would you like to ask something?
So one question to both of them. Rupesh sir, if you want to give non-steroidal MRA, Finrenon, in diabetic kidney disease, in heart failure, which is recommended. But at the same time, if I wanted to use as a molecule which has already been stating, like we are using MRA for heart failure, do we, are we at the stage where we can completely recommend Finerenone for heart failure, be it diabetic or non-diabetic?
I think, see, Finerenone, basically HepRef, HepMref and HepPef, I think there is no clear-cut guidelines, but I think for the trial purposes, I think we have divided like the 40, 40 to 50, 50 to 60 or more than that. But I think majority of the trials, they are for HepRef, but I think non-steroidal MRAs, mainly for the HepMref and HepPef. So after diuretics and SGLT2 inhibitors, I think this is the one molecule. Of course, GLP-1 agonist which are there, but I think this is already proven therapy because of the fine heart failure therapy. But in future, I think another 4 trials which are going on with the Finerenone, maybe, I mean, Dr. Jay Gopal is may put some light on it in high HepRef patient also. Non-steroidal MRS with SGLT2 inhibitors, I think it's also another good combination. But at present, it's still not recommended. But looking to the trial, I think we can push them in the HepMref and HepPef, because still it is not included in the guideline. In future, it may come in the guidelines of the HepPef patient.
Yeah, I think the data from the financial is quite promising. But I think the only problem with the issue is that hard outcomes are not there in FF. So you are basically going to look at the quality of life, and then all of us know the HFF is actually a disease of various comorbidities. So how it will evolve over a period of time, but what is even more striking is probably the GLP agonist. So I think in the context of the newer drugs come in, I don't know, it is too premature to jump into the conclusion that Finerenone will totally replace. And again, if you look at the TopCat trial also, aldactone in the spironolactone, it did very well in the in the American population, but not in the used European. So again, there's again questions raised about the whether they were truly heart failure patients. I believe that there's a big thing coming up saying there's an industry bias also in this Finerenone trial. So I think too early days. We still have to wait for much larger data before we think that we will replace all the MRA with Finerenone.
Suppose there is hyperkalemia with spironolactone. If we want to restart, probably we can think of Finerenone. I don't know still, because hyperkalemia is little less
hyperkalemia.
Less hyperkalemia.
But so I think the current thinking is, you treat hyperkalemia with other agents. So again, there is a bias there.
And Dr. Sanjeev,
My question to Dr. Sanjeev, you haven't touched refractory hypertension and how you will treat, and to all the eminent cardiologists, what is the prevalence of this refractory hypertension in our population?
So first is a refractory hypertension is more of a subset of itself. It's an for of a resistant hypertension. But for the resistant hypertension, we have the identifiable causes are there for the resistant hypertension. So resistant hypertension will more prevalent for the females. Resistant hypertension will have more of an obstructive sleep apnea will be there for the resistant hypertension. So if you treat more of an causes for the resistant hypertension, causes like obstructive sleep apnea, or patient is already on any non-steroidal anti-inflammatory medications or anything, if you treat that cause, then patients will be having better control of the hypertension. But without any cause, patient doesn't have any obstructive sleep apnea, patient doesn't have any drug medication history also, and because of its inherent sympathetic nervous system overactivity, despite of multiple medications, patient is not getting treated within good control of the hypertension, then we stamp it as a refractory hypertension. And definitely refractory hypertension, at the end they need with the multiple treatment. If it is not getting controlled, definitely intervention is needed in the form of renal denervation therapy.
so what Sanjeev has told as an extension to renal denervation, 3 important things which we need to remember for RDN, that is renal denervation therapy. One, that if I use only RDN without any antihypertensive drugs, then what will be the reduction of blood pressure after that procedure? That reduction is in the range of 19 millimeter of mercury. That is in simplicity 3 track. That is number 1. Number 2, if I use 3 antihypertensive, which is the actual treatment for resistant hypertension, and if patient is convinced for RDN therapy, then the reduction would be in the range of 34 to 35 millimeter of mercury. The 2 drawbacks of RDN, one is the cost, around 8 lakhs for that therapy, device therapy. Second drawbacks, it does not produce any major, I would say, it's not recommended even for ESRD or a kidney compromised patient. The main area of concern of resistant hypertension is either CKD or stage 3 or 4 CKD, where hypertension is one of the major cause. And you are having a lot of patients, those who are having uncontrolled hypertension with CKD. But in that subset of patient, if the eGFR is less than 40, RDN has not shown any major reduction. So that is the main drawback. Otherwise, in a normal individual with a good eGFR, I think RDN is probably going to be the future device therapy for hypertension treatment.
Thank you. I think I would request Dr. Hitesh Patel to felicitate our first speaker, Dr. Bhupesh Bhai, and then would request Dr. Nalin Ghiwala to felicitate our second speaker, Dr. Sanjeev Prajapati, and then would request Dr. Jay Shah to come on the dais to felicitate our chairpersons, Dr. Shaurin Shah to please come on the dais, and Dr. Utsav Unarkar to come on the dais to felicitate our experts. Dr. Utsav, Dr. Anand Bhai, okay. So it had been an extensive day. As they say that education is the passport to the future. For tomorrow belongs to those who prepare for it today. And all of us have become a little wiser today. And I would request Dr. Jay Shah to give vote of thanks. And then after his vote of thanks, would like to invite a very important dignity, a very important person who has arrived here. Television gives everyone an image, but radio gives birth to 1 million images in 1 million brains. We start our day from the radio, जो एक ऐसा माध्यम जो हमारे दिलों पर, हमारे जहन में एक इमेज क्रिएट करता है, just from their speech. So we have a very important person who has arrived here, RJ Dhwanit, and I would request RJ Dhwanit to come on the dais and take a seat. And we are very eager to listen to him. And Dr. Jay Shah, please.
Very famous statement from Dhwanit Bhai. Dhwanite kidu at a final. Yeah. So, thank you so much, everyone. Just a thank you word is not enough for the amount of relentless efforts what we have kept. I am extremely grateful to the guide and the teacher, Dr. Bhupesh sir, and all my team members, starting from Dr. Bhavesh sir, Dr. Anand Bhai, Dr. Tarun Madan, very close friend, Dr. Shaurin Shah, Dr. Utsav Unarkar, Dr. Sanjeev Prajapati, Dr. Dhruv Jadeja, Dr. Neerav, Dr. Devang, Dr. Utsav Patel. Apart from that, I think my event team, which is headed by Kapil Bhai Pandya, Hari Om, that is what everyone knows.